Good morning and welcome to the community conversation on prostate cancer in Detroit. My name is Chuck Strand. I am the CEO of Us2 International. We are a nonprofit that provides educational resources and support services to the prostate cancer community at no charge. And we are very happy to be here this morning to present some very important information, and we'd like to thank Dr. Michael Lutz and the Michigan Institute of Urology for hosting this men's health event. So we'd also like to thank all of you, everyone that's coming in to be part of the conversation. In addition to the folks who are online, we'll be providing this presentation through online streaming video. So throughout the broadcast, if any of you who are joining us online have any questions or comments, please post those to the website, and we'll go ahead and do our best to read those and get them into the conversation. We'd like to also thank all of our sponsors and the importance of today's information. So it's going to be all about informed decision making throughout all aspects of prostate cancer, from the importance of getting tested to the option of active surveillance, in addition to the various treatment options and the management of side effects. So it's important information. And again, thanks so much for being here, and thanks to our sponsors. So why is this so important? Why does it matter, specific to prostate cancer? I mean, this event is all about men's health, and all of the different information that's being presented at the event today is important. But specific to prostate cancer, it's very important to be informed because there really is a lack of awareness about prostate cancer. And it's also important to recognize that there are no symptoms for this disease. Until it's advanced, it's very difficult to detect unless you do the testing, which is the PSA and the DRE, and potentially a biopsy. There's also confusion over this PSA. It stands for prostate-specific antigen. It's a blood test, and there's been some confusion because the United States Preventive Services Task Force back in 2011 dissuaded people from getting the PSA because if they don't want to have people get overtreated or undertreated, which is a valid point, but it's important to, since that's the best test that we currently have, it is important to recognize that it's really the only gauge we have for potentially giving a red flag for prostate cancer. And once diagnosed, there really is no best treatment, and that's another reason why this conversation is so important, to really get the information that people need in order to ask the right questions, to get the right information, to understand what's going to be the best option for their specific situation moving forward with managing prostate cancer. If someone decides to go ahead with a treatment, it's important to understand that whenever there's a treatment, there are side effects. So active surveillance is an option for many people, depending on the level of the Gleason score after the biopsy. But if treatment is pursued, there are side effects with every treatment. A lot of people out there think that prostate cancer is one of those diseases that you're not going to die from prostate cancer, you're going to die from something else. In many cases, that is true, but there are 30,000 guys approximately every year who pass away from prostate cancer. So it's an important health issue, and again, very important to pay attention to it. So thanks for being here. Our outline for the conversation today is really covering a lot of information in a little bit of time. So the reason for the slide deck is not to have a presentation, because we really do want to have a conversation, back and forth, questions and answers, that type of thing. But to kind of keep us on track, we've got this path of information that we want to follow, and that's the purpose of these slides. And this gives you a quick snapshot of what we want to cover within the next 2 hours. We'll give a little bit of information on just the basics of prostate cancer, go into the importance of testing and screening and the diagnosis, the options of active surveillance or some other treatments, in addition to the side effects that come with those treatments. We'll talk a little bit about the education and support services that are out there for the prostate cancer community, and hear from a survivor, prostate cancer survivor, and have a little bit of time for a few comments from our sponsors for the community conversation, in addition to more formal question and answer portion of the program at the very end. And some of those folks who are going to help us to present would be Dr. Jason Hafron. He's a urologist with the Michigan Institute of Urology. And then Jim Nadeo is that prostate cancer patient that I referenced before. So Jim will tell his story too, so that'll come a little bit later in the presentation. So starting from just some of the basics, like, what is a prostate? Where is it? What does it do? So this kind of gives you a quick idea of what's going on. So The man's prostate gland is about the size and shape of a walnut, and it's located just below the bladder and just in front of the rectum. And the whole purpose of the prostate is to produce fluid that mixes with sperm. A few stats on the disease. As I mentioned earlier, it's the most common prostate cancer is the most common cancer for men following skin cancer. So it's important to recognize that. It's the second most common cause of death following lung cancer. Nearly 30,000 men die in the U.S. every year of prostate cancer, and there's about more than 200,000 who are diagnosed every year with prostate cancer. And those guys join the ranks of over 2 million men who are currently in the U.S. who have a prostate cancer diagnosis. And it's really important to recognize that as the baby boomer generation ages, that number is going to approach 4 million people in the next 8 years. So by 2024, we'll have more than 8 million men living in the U.S. who are diagnosed with prostate cancer. Some guys are at higher risk for prostate cancer. Age is really the biggest one, and the majority of men with prostate cancer are over 50, with the vast majority, with the majority of that portion, 65 or over. And ethnicity is also an important role. So African American men are more than twice as they're 60% more likely to develop the disease compared to Caucasian men, and they're unfortunately more than twice as likely to die from prostate cancer. If prostate cancer runs in your family, whether your dad, your grandfather, your uncle, brother has prostate cancer, it's important to pay close attention because it does run in the family. And guys who have prostate cancer, it's important to speak up because your sons and nephews have a better chance of getting the disease too. So those are all important things to recognize. Also, veterans, military veterans who served in the Korean War or Vietnam War who may have been exposed to Agent Orange are at a higher risk for developing prostate cancer. And some of the folks who work with chemicals such as firemen who are exposed to debris and dust and chemicals, that type of thing, also at a higher risk for prostate cancer. So right now, to go through some of the more medical aspects of prostate cancer, I'd like to introduce you to Dr. Jason Hafron. He's a urologist with the Michigan Institute of Urology. So please join me in welcoming Dr. Hafron.
Thank you, Chuck. Thank you, everybody, for joining us today. This is a great day. We're here at Ford Field for our annual Men's Health event. And this event is to support men's health. And one of the big, as Chuck alluded to, one of the big cancers, the biggest cancer in men is prostate cancer. So I just want to walk you through and explain a lot of the issues that we face on a day-to-day basis, the issues that I discuss with my patients, so that you, the patient, can better understand how to better treat yourself and how to better treat this disease. So basically, testing begins for prostate cancer with your PSA and your digital rectal exam. I'm going to walk you through about the PSA, the digital rectal exam, and then ultimately, if the PSA or the digital rectal exam is abnormal, we would consider a prostate biopsy. So let's talk about PSA. It's a very controversial issue. It's in the press a lot, but it's basically a blood test, and it measures prostate-specific antigen. There's no specific number that defines abnormal PSA, but the higher the PSA, the higher the likelihood you have prostate cancer. The number that we use at MIU as abnormal is 2.5, but we don't look at it at one point in time. We look at the man's PSA throughout his life, and is it increasing, is it shooting up? Those can be indications that prostate cancer may be present. So that is why we try to establish a benchmark or an early PSA in guys around that 50-year-old time point, sometimes a little bit earlier if the guy has a family history of prostate cancer. If the guy is African American, we'd want to check that PSA sometimes a little earlier. The guidelines with PSA are changing rapidly, but I think the key that we can never forget is that PSA saves lives, okay? It saves lives in every study we've looked at, and we have to use it, but also have to refine it with some new technology, and I'll talk a little bit about the new technologies that are helping PSA be a better test. So one of the confusing things and one of the frustrating things about PSA is that even if it's high, it usually doesn't mean you have prostate cancer. PSA is a non-specific test. It can be elevated usually for other reasons. It's a better measure for prostate health. So sometimes guys will walk in, their PSA is high, I could try to talk them down and say, you know what, it's probably not cancer. It's probably related to an enlarged prostate, which is a normal part of male aging. It could be related to inflammation or irritation or a prostatitis, or it could be simply related to recent ejaculation. It could be related to any manipulation of the prostate through a digital rectal exam, or it can even be affected by if a guy's riding a bicycle a lot. You know, those can cause false elevations, and that's the challenge and the frustrating part about PSA is that the PSA, an elevated PSA, does not always mean cancer, and it usually doesn't. So after we get a PSA, we'll typically do a digital rectal exam. That's the dreaded exam we all guys hate and fear, and it's part of the aging process. But a digital rectal exam is a necessary part of examining the prostate. It's where the doctor, the urologist, will place his finger in the rectum and actually sweep the prostate. What's interesting is about 15% of prostate cancer can be picked up on a digital rectal exam. A digital rectal exam is cheap. It's not a very expensive test. It's just a simple physical exam that we can do and can pick up a significant amount of cancer within men. And what we're looking for is on the backside of the prostate, we can feel the peripheral zone of the prostate, and we're feeling for a nodule. A nodule is like a hard, kind of like what your knuckle feels like, and that's typically what cancer feels like. And we can feel that quite commonly on these digital rectal exams. It's about 15% of the time. Reality is, the way we screen our patients in the US, most guys are picked up on an abnormal PSA, but we'll always check the digital rectal exam to make sure we don't feel anything. If the PSA is abnormal, if your digital rectal exam is abnormal, basically the next step in the diagnosis of prostate cancer is a prostate biopsy. The way a prostate biopsy works is we would place an ultrasound probe through your rectum, and then under ultrasound guidance would extract tissue from the prostate. Standard therapy today is a 12-core biopsy. It sounds intimidating, it sounds scary, but a prostate biopsy is not a big deal. We do them in the office. They're very well tolerated. We are able to numb up the prostate so a guy doesn't feel it. It's not something he wants to do every day, but in the end, he could go to work after the biopsy. He could eat before, he could eat after. It's really not a big inconvenience. The biggest risk of a prostate biopsy is infection. We'll give you antibiotics before and after the biopsy, but when we actually look at our numbers within our practice, our infection rate's only about 1.4%. So a lot of the negativity about prostate biopsy is pretty much untrue, or that we've developed a better biopsy scheme as well as a better antibiotic protocol so that we've minimized the risk of an infection. So biopsy, it's not something you want to do every day, but it's very well tolerated and it's not a big deal. We can do it in the office, and we can do it sometimes if a guy requests. We can even do it under anesthesia, and we'll do that occasionally as well. Once we take a biopsy, and if there's cancer, the next few slides I'm going to walk you through Gleason grade. And this is the most common question I get. Explain to me what the Gleason grade is. And I'm going to take some extra time and explain it to you so that hopefully everyone can understand this. If you have cancer, the tissue is going to be extracted, and then that tissue is sent to a pathologist. A pathologist is a doctor that looks at that tissue under a microscope and tells us whether there's cancer or no cancer. If there's cancer, they will give it a Gleason grade. Okay, this was developed probably 30 or 40 years ago by Dr. Gleason at University of Minnesota, and it's a good test because I know it's very predictive, but it's been around for 30 or 40 years. We have not found a better test or better way to identify prostate cancer than the Gleason grade. So this is well vetted information, and it's a good technique. The way the grade works is you're scored basically 1 through 5. 5 is the worst, 1's the best, and I'll talk about 1 in a second, but it's a score of how good or bad your cancer is, and that score tells us how to treat your disease. Okay? Grade 1 and 2 we don't really use. It's historical. It's fallen out of favor. We really only use Gleason grade 3, 4, or 5. 1s and 2s no one calls anymore. They're probably not cancer. And this is what the pathologist sees. Okay, You don't have to be a doctor or a scientist to figure it out. It's pretty obvious, and that's the simplicity of this, why Gleason grade has stood the test of time. Grade 1 and 2, let's start with grade 1, is how the prostate should look. Uniform glands are all tightly packed, and that's what a typical prostate gland looks like. If you go to grade 2, you see the glands get further separated or more space between the glands, and then grade 3 is where we see cancer. Grade 3, you see infiltration of the cells, and it looks different. Again, you don't have to be a doctor to see this. Grade 3 is a lot different than grade 1. So the glands aren't as tightly packed, they're infiltrating, they look different, and then as you go from grade 3 to grade 4, you get irregular masses of cells with few glands, you don't even see glands, and then grade 5, you don't see the glands at all. And that's a common theory of all, or thing we see with all cancers. As the cancer gets worse, it doesn't look like its original tissue, okay? So the grade 5 cancer doesn't even look like prostate glands. It's totally different or differentiated, so it's a very aggressive disease. So again, 5 is the worst, 3 is the best. These are all different grades of prostate cancer. What you'll see is we'll give you a score. If you have prostate cancer, you guys might have seen this, it'll be 3 plus 3, 3 plus 4, 4 plus 3. And the way that works, and this isn't brain surgery here, it's not rocket science, the first number is what the pathologist, the guy looking at the slide, sees. The first number is what he sees the most of. So if he says you're a 3 plus 3, if he says you're a 4 plus 3, the first number is what he sees the most of when he looks at all the cells. So that's the majority of the cancer he sees. The second number is the second most common cancer type you'll see. So if you're a 3 plus 3, you pretty much just sees 3s across the board. If you're a 3 plus 4, you mostly under the slides have 3s, and then there's a few areas of 4, okay? And that's how you get the Gleason grade. You take those two numbers and add it up. So basically, guys today diagnosed with prostate cancer will be a 6 through 10, 6 being the best, 10 being the worst. And with that, we've just recently changed how we graded it and made it even simpler, that we put them in 5 groups. So grade 1 prostate cancer is Gleason 6, and that's the new grading system. It came out about a year ago. Grade 1 is 6. Grade 2 is a 3 plus 4 equals 7. Grade 3 is a 4 plus 3. Grade 4, again, this isn't brain surgery. Grade 4 is a 4 plus 4 or an 8. And then grade 5, which we rarely see, thankfully, is Gleason 9 and 10. So you're basically, when you meet with your urologist, and unfortunately if you're diagnosed with prostate cancer, he's going to put you in a grade 1 through 5, which is basically a simplification of the Gleason scoring system. So let's talk and shift gears a little bit. Once you get the diagnosis of prostate cancer, once you get your Gleason grade, you know your PSA, you know your digital rectal exam, now what? What do we do, or how, as a urologist, determine how to treat your disease? It's not really a new concept, it's one of the concepts that's been around forever, but what we're doing more of is something called active surveillance. And what active surveillance is determining whether you need to be treated or not treated. It sounds crazy, but there's a lot of prostate cancer out there that's not going to kill you, that's not going to spread, so why do we have to treat it? Okay, and we're seeing more and more data about this where we can monitor your disease to make sure it never spreads or never be cause of your death. And that's the majority of the prostate cancer we see today is this low risk, low grade prostate cancer. And that's when your urologist will talk to you about active surveillance. It makes sense. We basically only do active surveillance on Gleason 6, low grade, low volume disease, or grade 1 disease. Sometimes, depending on the clinical situation, we may consider active surveillance for a Gleason 7 or a grade 2 disease. But that's a discussion you have with the urologist, knowing the good and bad of each of these to determine whether you want to do surveillance. The thing about surveillance is it's not you have it, see you later, call me in 5 years. It's we will monitor your disease. Typically, we repeat a PSA every 6 to 12 months at least. I do about every 4 to 6 months, and then you require repeated biopsies every 1 to 2 years to monitor it. The challenge that we have with active surveillance is, as a urologist and as the patient, do you have a tiger-type prostate cancer, or do you have a little kitten-type prostate cancer? Is it aggressive or is it non-aggressive? And it's this tiger or kitten. Is it a slow-growing tumor or is it an aggressive tumor? And that's what the challenge that we're faced to determine whether we can do active surveillance. Because nobody wants to be over-treated. You know, if you don't need treatment, why would you subject yourself to therapy, to surgery? And nobody wants to be undertreated. Why would you want the prostate cancer to spread or get worse? So one of the things that, and this has just come up in the last 2 or 3 years, there's been a lot of development and new markers to look at prostate cancer. There are new prognostics. They're here. A lot of these companies are here with us today, where they'll take the RNA or the genomics of your cancer, pull out the DNA, and based on these studies, they can give you an additional predictive chance of this spreading. And when you look at these tests, and they're I call them molecular tests or genomic tests, these are performing at a higher level right now than Gleason grade and PSA and digital rectal exam. So we're just at the tip of the iceberg for these new tests to better determine on who should be treated and who should not be treated. There's about 4 of them on the market today, and as the technology develops, we'll see more and more higher performing tests years going forward, which will tell us whether you have a tiger or a kitten type of prostate cancer. Do we need to treat you, or can we sit and watch you? And that's where these molecular tests or genomic tests will make a huge difference. They're very helpful in the clinic, and they show great utility when urologists use them to help determine who should be followed and who should be treated. I'm going to stop for 1 second. We've given a lot of information. Does anybody have any questions on what I've talked about up to date? Anything not make sense? Yes, sir. So the question was, what is the procedure for a biopsy? A biopsy is an office-based procedure, typically. You would come into the urologist office, and he or she would place an ultrasound probe in the rectum. It's a small probe, don't worry. It's uncomfortable but not painful. And then the urologist would numb the prostate. Similar to like a dentist numbs your mouth, we can deliver lidocaine or anesthetic into the prostate, deaden the prostate, and then he or she will go ahead and take 12 samples of your prostate. Afterwards, you could go to work, you could go home. It's not a big deal. Some of the side effects you may see with a biopsy, you may see some blood in your urine, blood in your stool, blood in your ejaculate that can come and go for about 4 to 6 weeks. It's pretty well tolerated. The biggest risk we worry about is infection. Again, the infection rate, which we see within our practice, which we monitor very closely, is about 1.4%. So an infection is pretty rare, but that's probably the biggest risk. A prostate biopsy is not a big deal. It's not something you want to do every day, but it's very well tolerated, and most guys won't have an issue with it. Yes?
Are you going to discuss foods that would help to keep a prostate healthy?
Foods? Yeah, at the end we can talk about that.
Okay.
Yeah. That's a great question. That comes up a lot, is what foods or nutrition to improve prostatic outcomes. Yes?
When you mentioned about the pathologist and making a grade of a 3 plus 3 or 3 plus 4, so when they're making a determination between a 3 and a 4 for the second number there, is part of just some subjective, or I know you said it's based on how it looks and how many.
Right. So the question was, how does the pathologist determine the 3s versus the 4s or the 5s? There is subjectivity to it. It's one guy or he or she looking at it, a specialist, a pathologist, to determine is it a 3 or 4. So I agree, there is subjectivity to it, and sometimes we'll get second opinions or ask other guys to look at the slides. But when you look at that data, when we get second opinions, most pathologists today are very good at calling it. And that's why we still use Gleason score, because it's pretty easy. You know, I'm not a pathologist, but they're pretty uniform from pathologist to pathologist in what they see. But I agree, there is some subjectivity, and if there's a question mark, it's not a bad idea to ask your urologist to get a second pair of eyes to look at it and see if he or she agrees with the initial diagnosis. We'll do that a lot. Or if you're in a community where there's not a high volume of prostate cancer being diagnosed, it might not be a bad idea to send it to a tertiary or a larger center where you can have a specialized pathologist who's used to seeing a lot of prostate cancer take a look at it. But even in those settings, you don't see, it's shocking, it surprises me, there's not a lot of variation between different guys reading it. It works very well.
Is the genomic testing available through your urologist?
Yeah, genomic testing is a send-out lab, and the way it works is kind of cool. So they'll take your biopsy specimen and extract the RNA or the DNA from that biopsy specimen and send it out to a lab. And most of the labs I think all of them are in California, they're all on the West Coast. They will process that RNA, and they use various factors or various methods. Each company looks at it a different way to predict what's your chance of this spreading, what's your chance of you dying of this disease, what's the chance that this is more aggressive disease than your Gleason score says. Again, it gives you additional information to help you decide how to treat your disease. Do we do active surveillance? Do we need to do radiation plus hormone therapy? How aggressive we have to be? And what you're starting to see in some of these markers, it's new and it's evolving, is some of these markers are performing at a higher level than Gleason, PSA, and DRE. So it's kind of the new tip of the iceberg. We're seeing a revolution in this area, and it just has to do with genomics and more advanced molecular studies so we can better treat or more appropriately treat our patients so that we don't undertreat or we don't overtreat our patients. Yes, Chuck. So one of the questions from online came about it through our online listeners is random biopsying versus MRI biopsying. So there's new technology out here. I've talked about the transrectal ultrasound office-based biopsying, but now what we're starting to see, and it's been around for a couple of years, is MRI-guided biopsies. And the way that these work is a patient will go get an MRI of his prostate, and then the MRI, about 70% of the time, will identify the cancer. Using very advanced machines, we can literally take the MRI image, put it in our ultrasound image while we're biopsying to literally biopsy that lesion, okay? So we can see the cancer on the MRI if we can't always see it, and biopsy the actual lesion, which is revolutionary. It's state-of-the-art ways to detect prostate cancer. So right now when we do a transrectal ultrasound, we just take 12 random samples. With the MRI, most guys are still taking the 12 random samples, but if they see a lesion, they'll direct typically 2 to 4 biopsies in that lesion. What we're seeing with MRI fusion biopsies, that's the fancy name, with these MRI biopsies, we are diagnosing more Gleason 7s, more Gleason 8s, and we're finding less Gleason 6s, which is a good thing, because in all honesty, we don't want to find Gleason 6s because we're going to follow them. We'd rather find intermediate or high-risk prostate cancer, and MRI fusion biopsies are allowing us to do that. It's new novel technology. The biggest limitation is that most centers around the United States can't read the prostate MRI. It's a very complicated study. Guys don't have a lot of experience reading these yet, and it's very difficult to call the lesions on MRI. It's something like 1,200 images these guys have to look at to find 5 millimeters of cancer. But I think that, again, is a new revolution or the tip of the iceberg of how we're moving forward. So we're moving away from the ultrasound-guided biopsies to MRI fusion-guided biopsies, and that's just the start of the future. Any other questions? Yes, sir. Yeah, the question was, when we numb the prostate, do you feel a lot of pain? Typically not. I mean, most guys say it wasn't painful, and then they say, but I never want to do it again. You know, so it's more awkward and uncomfortable, but not really painful. The numbing works very well. It's like getting your tooth filled. It doesn't hurt, but you don't want someone digging in your mouth the same way you don't want to have something in your rectum. But it's tolerable. It's not something you want to do every day, though. Okay, we'll keep moving. So we talked about active surveillance. We're seeing more and more active surveillance today, and those are all great questions about fusion and about the molecular markers. Those will continue to evolve, and I strongly encourage you to ask your urologist about that, because I think they're very helpful. Prostate, let's talk about treatments. Active surveillance I consider a treatment. It's following. But prostate cancer is one of the very few cancers in your body where you have a choice in how you want to treat your disease. Whether you have colon cancer, lung cancer, it's pretty much worked out for you. You go from A to B to C. It's basically very algorithmic, where you just follow a recipe. Prostate cancer, you have a choice, okay? It's good and bad. Some guys like the choice. Some guys get frustrated and overwhelmed by the choice. What I try to relate to the patients is give them a menu, a choice of what are reasonable options. And to be honest with you, it comes down to the side effects. What causes the least side effects or what you're most comfortable with? The analogy is it's like going to Chicago. We'll get you to Chicago. We're in Detroit today for those of you watching online. We'll get you to Chicago. We'll cure you of this disease. But how do you want to get there? Some guys like to fly to Chicago. Some guys hate to fly. They'd rather drive. Some people say, I'd rather be on the train. And that is very similar to how we treat prostate cancer. Everyone has their own biases, their own comfort levels, and our job as a urologist is to let the patient decide on how they want their disease to be treated. And part of the mission of US2 is to inform our patients to use US2 as a resource to make an educated decision. You know, people always come into my office, sorry doctor, I looked on the internet, I'm sorry. I think that's great, because then I can have an intelligent conversation about the good and bad of every disease. So I encourage you to go to websites like US2. I encourage you to talk to your friends who've been treated, to talk to other prostate cancer survivors, because that's how you're going to understand the treatments themselves more than I can offer, to be honest with you. I can tell you medical stuff, but the guy who's done it will give you more information. When you look online and read patient testimonials or see videos, that will give you a better understanding of how you want to treat your disease. So the two big players in early and intermediate prostate cancer is surgery and radiation. These have been around the longest. Standard surgery today is a robotic prostatectomy. Basically, it's a 2-hour operation, a one-night stay in the hospital. You have a tuber catheter in your penis for 7 days. With the robotic surgery, it's evolved. We've been doing it's not a new procedure. We've been doing it for 12 years now, and it's become our standard approach. The two biggest side effects of robotic surgery are erectile dysfunction and incontinence. Incontinence is actually very rare. Typically, it's temporary. You will leak or have to wear a pad for a few weeks to a few months. Then eventually that will go away. Erectile dysfunction is a little more nebulous or misleading. A lot of it, to be honest with you, without sparing you the details, is erectile function after the procedure really is dependent on where the man's starting prior to the procedure. If he's having good erectile function and he doesn't have high volume disease and we can spare both the nerves, you're looking at about a 75% chance that guy's going to have good erections afterwards. The guy who's not doing well, has some ED or is seeing some deficiencies, his erections aren't going to get better after the procedure. They never do after any surgical procedure. They might get slightly worse. Is it worse enough where he can't maintain an erection for intercourse? That's the challenge, and that's a one-on-one discussion with your urologist based on where you're starting with. The other big treatment modality we use a lot is radiation. Radiation is using literally radiation to kill the cancer. There's two main ways that we deliver radiation. It's external beam, where you'll come for 7 to 8 weeks, Monday through Friday, and get 10 minutes of treatment. You'll go on the machine, and the machine will use X-ray energy to zap the cancer. Another way that we use a lot is high-dose brachytherapy, where we will use, I call it straws, where we'll put straws into your prostate. They're not really straws, but they act like straws, and we can deliver the radiation directly into the prostate gland. and that's called high-dose brachytherapy. Typically, the advantage of high-dose brachytherapy is we can usually do it in 1 or 2 treatments, as opposed to 7 to 8 weeks of treatment. So it's much more tolerated, a little more invasive, but it speeds things up. The other thing that we do less and less of today is seeds. A lot of guys have heard of seeds, where we'll take radioactive seeds through the perineum, that area between the scrotum and the rectum, and put in these radioactive pellets, and that will kill the cancer itself. The problem with seeds is the patient's radioactive for a few months after it. They can't be around their grandchildren. You can pee out the seeds, you can ejaculate the seeds out, so there is some risk to the family members. That's why at Beaumont we've moved away from seeds and moved more to the straw procedure or high-dose brachytherapy, which both of these are very effective. Again, side effect profile is a little bit different, surgery versus radiation. Radiation side effects are less incontinence, but more irritative voiding symptoms, frequency, urgency, blood in your urine. Sometimes you'll see change in bowel habits, may see bloody stools, loose stools, things like that. And it will also affect your erectile function as well. So again, it goes back to, what's the least worse? No one wants to do any of this. Who would want to do any treatment? But you got to pick a treatment, if your cancer requires it, where you could have a side effect that you are comfortable with, okay? Another thing that we use sometimes is hormone therapy. Usually in early stage prostate cancer, we'll use hormone therapy with radiation. Typically we'll do 6 to 12 months of hormone therapy with the radiation. Very rarely these days we use hormone therapy alone. We usually typically in combination with other therapies. Chemotherapy is usually in high-grade disease. We'll use it with very bad prostate cancers, and typically chemotherapy in early-stage prostate cancer is used on a trial basis. Another local treatment option is HIFU, high-intensity frequency ultrasound. This was just approved last fall. It's been in Europe for about 20 years, and it basically is kind of a cool technology. Through the rectum, you can deliver high-intensity frequency ultrasound. The ultrasound energy causes essentially heat within your prostate. The heat will kill your prostate. We did an initial trial 2 years ago where we used transurethral HIFU and an MRI scanner. Instead of going through the rectum and avoiding rectal toxicity, we went through the urethra. It was our phase 1 trial. The outcomes were very good. Side effect profile looked great. Cancer control was good. And now we're going to open up our phase 3 trial, hopefully by the end of this year, to offer our patients at Beaumont transurethral HIFU that's guided by the MRI machine. So it's high technology that looks very promising at this point. Another therapy that we use quite commonly is cryosurgery. Cryosurgery is, instead of heating the prostate, we freeze the prostate. We freeze the prostate so cold that we kill the cancer. Cryosurgery is nice because it can be done as an outpatient. We put in these cryoprobes, we call them popsicle sticks, right in the perineum, between the perineums, between the scrotum and the rectum, and then under ultrasound guidance, we can freeze that prostate so cold that we kill the cancer. The problem with cryosurgery is that we can't preserve erectile function, so we typically do it on impotent men, but again, it's very well tolerated, not a lot of side effects, and not a lot of risk with the procedure. Outpatient procedure, it works quite well. So those are the mainstays of treatment for localized prostate cancer. That's the typical starting point of how we treat prostate cancer in 2016. Does anybody have any questions about the treatment options? The question was, we have all these options available. What role does the urologist play in making that treatment decision? The role of the urologist is to work with the patient, lay out what the options are, get the second, the third opinions in the various specialists, and then help the patient understand the good and bad, help the patient make the decision on what's best for him, as well as her, because prostate cancer does affect intimacy, it can affect erectile function. So it's also nice when a partner is available, a partner involved in that decision tree. But I think the urologist plays a critical role in letting the patient or giving the patient the appropriate information to help make a educated decision on what's best for him and his partner.
So we had a question come in that said, on September 29th, I'll begin chemo treatment with Taxotere. My urologist told me that studies show that the increase from 6 to 10 treatments is more beneficial, resulting in increased survival. There's also an article about this in the October issue of the Hot Sheet. Could you please comment?
So what I think our online patient is referring to is sometimes patients will present with prostate cancer. They'll walk in the door and the prostate cancer is already outside the prostate and spread to the bones. Okay, so it's metastatic prostate cancer. Fortunately, we only see this about 5 to 6% of the time, so it's not a very common thing. What the patient is referring to is there's new Charter data and Stampede data that will show if we give these very high-risk prostate cancer patients docetaxel, they will do better than just giving them hormones. So 2 years ago, those guys walked in the door, we just put them on hormones. Now there is data to support in metastatic, high volume, and even low volume prostate cancer to the bone. We will start with chemotherapy, typically six treatments, and in combination with hormone therapy. So I agree with that. That's kind of the new novel way to treat it. It's cutting edge data on how to treat metastatic prostate cancer at initiation. So that's great, and that's what we use when these patients walk in the door, is a combination of chemotherapy and hormone therapy will lead to better outcomes. Yes? So another new concept, it's not that new, it's been probably around for 5-ish years, is focal therapy, okay? What I talked about is whole gland therapy, where we remove the whole gland, we treat the whole gland, we freeze the whole gland, we do HIFU of the whole gland. One of the newer things that we're seeing or doing more of is something called focal therapy. And what focal therapy is, that we just treat the area of the prostate gland where there's cancer. Using new technologies, most of it's MRI guided, using HIFU and cryo, if we suspect that the prostate cancer is in one spot of the gland, we'll focus all our energy, HIFU, freeze that part. The advantage of focal is that it has less side effects. We see less problems with ED, less problems with incontinence. The challenge is identifying the appropriate patient for focal, because not everybody's a candidate. Not everybody has a lesion in one spot. We typically don't do focal on high-risk disease, Gleason 8s. We typically reserve it for small volume, non-aggressive prostate cancers, but it is a nice trick or a nice therapy when in the appropriately selected patient. I think the key with focal is appropriate patient selection. It's a great idea to bring up to your urologist to see if you are a candidate for focal therapy, because this area of prostate treatment right now is exploding, and there's a lot of novel, new, interesting ways to treat the prostate gland in one area. All right, so we'll move on, and we're going to shift gears. So that was mostly how you treat prostate cancer if it's localized. One of the most exciting new areas is if it gets out of the prostate, if it starts to spread. In the last 5 years, there has been major breakthroughs in the treatment for advanced prostate cancer. We have 5 or 6 new drugs that are available, and we have 5 or 6 new drugs coming. This area, it's incredible on how we have changed the face of urology or the treatments for advanced prostate cancer. Month to month, year to year, this area is exploding. It's incredible. So that we're trying to get advanced prostate cancer so that we can make it a chronic disease. Unfortunately, today, we can't cure advanced prostate cancer, but we have 6 new treatments, 6 more coming. The goal is to make this a chronic disease, eventually make it a cure. But we're not there yet. We want to make it a chronic disease similar to diabetes, we can't cure diabetes, we can't cure hypertension, but we can give you pills and treatments to control it. And that's kind of where we are today with advanced prostate cancer. Advanced prostate cancer is, again, if the prostate cancer leaves the prostate and goes into the bones, the lymph nodes, the liver, the lungs. Usually it's the bones or the lymph nodes, but it can theoretically go anywhere. Less commonly the liver or the lungs. Usually goes to the bone and lymph nodes. And that's what I'm going to focus on, and that's the hottest area of urology today. Typically, if the prostate cancer leaves the prostate, we would start hormone therapy. It's basically a shot every 1 to 4 months, and it takes away a man's testosterone. Testosterone is the food that fuels the cancer. So if we can give you a shot that will take away your testosterone, we're taking the food away so that this cancer doesn't continue to grow. Shots do have side effects, okay? A lot of guys, pretty much all of them, will get hot flashes. They might feel tired. They might gain some weight. That's pretty typical. So hormone therapy is effective, but guys will feel it. So, and guys don't love it, but they can deal with it. It's very manageable. I think hot flashes and fatigue are the most common complaints we see in our practice. One of the new options too is chemotherapy. That came in from one of our online questions. We're using chemotherapy, docetaxel, at an earlier stage for prostate cancer. And we're also using it in the late stages of prostate cancer. Docetaxel has been around the longest, and it's very effective and it works, but it does have a lot of side effects. It is a chemotherapeutic. So it does work. The other new thing that we use a lot of is something called immunotherapy. It's called Provenge. And this represents the new frontier or novel ways to treat any cancer. This was one of the first ways to treat cancer, and it happened to be, thankfully, in prostate cancer. And this technology is incredible. The way it works is you take a man's white blood cells out of his, or antigen-presenting cells. You take out the cells of his body. You take them and you send them to a lab, and then they're reprogrammed. You reinfuse these cells a week later into a guy's body, and what it does is it triggers an immune response so that his body will kill the cancer. So we're using a man's own immune system to kill prostate cancer. It's amazing. It's revolutionary, and it represents the future of most cancer therapies, is using the own immune system to kill the cancer. The nice thing about immunotherapy is the side effect profile is very, very good. The only time it's very well tolerated. The only real problems we see when we use this therapy is that he might get a fever during infusion, but it won't cause hair loss, it won't cause anemia. It's very, very well tolerated. Typically, this is our first step in how we treat advanced prostate cancer. It's 1 month of treatment. We get the immunotherapy in. It's called Provenge, and that leads to a lifetime of using your immune system to kill the cancer. Very effective with not a lot of risk. Another new technology that's not new, but it's improved, is radium-223. It's a radiopharmaceutical. It's made by Bayer, and this technology is incredible too. Basically, it tricks the body to thinking that it's an infusion of radiation. And the nice thing about it is it goes right to the bones. It goes right to the cancer, emits a low dose of radiation, and kills the cancer right in the bones. Okay? It's very safe, very well tolerated. It's 6 treatments over 6 months. And when you look at the data on radium-223, it's very rare that the guy we can control the disease in the bone after he's gotten radium-223. It will improve his survival, and will also is effective in taking away pain. So if you have cancer in your bone, prostate cancer in your bones, radium-223 will take away the pain as well as allow you to live longer. And it's just monthly injections for 6 months. It's very well tolerated, very effective. We're going to be using more and more of this in the coming years as concomitant therapy in conjunction with all our other therapies. As far as the side effects, I touched on this a little bit. You know, most of the localized therapies, the HIFU, the radiation, the surgery, you will see some mild urinary incontinence. We will encourage guys to do Kegel exercises, Women are typically very familiar with Kegel exercises. It's the same exercises that women do, and that will help control urinary continence. Sometimes guys will have to wear pads, and typically that's temporarily and will go away. But if a guy can't get rid of the pads or is having significant incontinence, typically we'll consider something called a sling, which is a mesh implant, which will tighten up the urethra so there'll be less leakage. Or sometimes in very severe cases, you may get an artificial sphincter, which can control your urethra, so it's kind of on and off control if you have very severe urinary incontinence. I think the bottom line is if you have a complication of incontinence after surgery, after radiation, there's very effective medical surgical therapy to treat this. And I think it's important that you speak up, let your urologist know that you're having these issues, because there are treatments very effective that can manage these problems very well. The other big side effect which I talked about is erectile dysfunction. Erectile dysfunction is common in surgery, it's common in radiation, it's common in HIFU, cryo. You know, anytime you treat the prostate, however you're treating it, whether you're freezing it, cooking it, or removing it, you're gonna see some form of erectile dysfunction. The good news is we have great treatments. In 2016, based medical technology, we can get the penis hard. We can treat erectile dysfunction very effectively. As many of you know, and we see on TV all the time, there are great pills out there, the PD5 inhibitors. There's 4 of them. They're very effective. They work very well. When those don't work well, we also have penile injections where we can inject medicine. You teach our patients how to inject medicine right into the penis. Those work very effectively. We also have these capsules, or these tiny little pellets that you can put inside your urethra or your P-tube, and that will get an erection. The bottom line is if you're having ED, ask for help. There are things we can offer. You don't have to suffer. Speak up, and there are treatments we can do to give you satisfactory erections so that you can have intercourse or be sexually active. In very severe cases, there's even surgery. There's surgery where we can do implants, where you can actually put a penile prosthesis, we call them pumps, and you can actually have a pump that's inserted into your scrotum and pump up the penis and get a full erection. Sounds crazy, sounds intimidating, but when we evaluate patients on how they feel after they've gotten through surgery, they are happier than people who are on pills or injections. I agree, it's hard to get over that hump to go for surgery, but once you get over the hump and everything heals up nicely, patients are very happy. I can't stress enough, do not suffer, or if you're interested in being sexually active after prostate surgery or treatments, speak up. There's a million options available so that you can have intimacy, you can be sexually active. We're not going to know as urologists unless you tell us. In the advanced disease, you know, we talked about bone. Bone is where the cancer likes to go, and sometimes you can see skeletal-related events. Skeletal-related events are when the cancer goes into the bone. Sometimes we'll have to treat those with radiation. Sometimes we'll have to send them to surgery to fix the bones. Sometimes you could have cord compression. These are complications, or late-stage complications, that fortunately we do have very effective treatments for these, and typically we can manage these very well when they come up. And these are pretty much restricted to evidence of bone metastasis. If you're on hormone therapy, it's important, I can't stress this enough, that you're on a bone health program, that if you're on hormone agents or you have cancer in your bones, you need to be taking vitamin D, you need to be taking calcium, and then there is medicine that you should be on as well to strengthen your bones. That has been shown to be effective. If you're having painful bony metastasis or complications related to the bony metastasis, it's important that you strongly consider radium-223 or Xofigo. That will help manage that disease. I'm almost finished here. So one of the things that us two, MIU Men's Health Foundation, focus on is being a survivor of prostate cancer, being a survivor of any cancer. There's a lot of anxiety and depression associated with this, but the key is that most of these cancers we can treat. Most of prostate cancer, most men won't die of, but they'll live with lifelong complications, lifelong anxiety associated with this cancer. That's why we're here today. That's why us two exist. We have support groups available. We meet monthly with other survivors to talk about the good and bad of prostate cancer. And what I hear day in and day out from the survivors is, I'm good until I get that letter in the mail, I gotta go get my PSA checked. I don't think about it, but that week where I gotta go in, get my blood, and then go see my doctor, I'm freaking out like I was when I was initially diagnosed. That's normal, okay? That's part of life of being a survivor. And that's why we're here to get you the help so that we can treat the stress anxiety. We can treat the complications of ED. We can treat the complications of incontinence. If you're having intimacy problems with your wife because sexual function's a little different, we have resources for you and your wife to understand or be sexually active after treatment for prostate cancer. The key is that it's being a survivor, and as a survivor, you gotta seek out seek out ways to get these problems fixed. Okay, and there are options available to you. Go to the US2 website, come to our men's health event, come to our monthly meetings, talk to other survivors. You know, men in general are poor, aren't good healthcare consumers. Women have issues, they talk to their girlfriends, they talk to everybody in the whole block. Men keep it to themselves, and that's wrong. Because if you start asking the questions, whether you or your wife, you'll see that most men, friends, uncles, brothers, you know, guys you work with will probably have dealt with prostate cancer more than you know. And the more you talk about it and discuss it with other men, you'll feel more comfortable and more normal, and you won't just survive prostate cancer, you'll thrive prostate cancer. So I want to thank Bayer Healthcare for giving us this unrestricted grant, US2 Foundation for allowing me to speak here, and thank you for attending MIU Men's Health Foundation event.
And thanks very much. We have a couple more questions if you're
Sure.
up for
Yeah.
First of all, anybody in the audience have additional questions they wanted to ask? Oh, okay, 1 second.
Yeah, I just wonder if you've used the sodium fluoride or the 18F PET scan. I know there's the acetate one and the choline out of Mayo Clinic. Just wondering if you've used it.
Yep. Yeah, so the question was, have we used or do I use the sodium PET scan? Yes. So let me back up a second. The way to detect prostate cancer in your bones is a bone scan. The standard way was a technetium bone scan, which is good, and it detects a lot of bone cancer. One of the newer agents is a sodium fluoride PET scan, which is a little bit better, about, I would estimate 30 to 40% more sensitive. So that's a very effective way. The problem is most payers in Michigan won't cover it. Medicare through the NOPRA registry is covering it, so we're doing it on a registry trial for our Medicare patients, but most private payers today aren't covered in the state of Michigan. It's being well covered in California, in other parts of the country, so I encourage you to ask for it, and it's really state dependent on the coverage. It's a great test that is more sensitive than a standard bone scan.
Yeah, do you know how low it will actually read if you on your PSA? Say if you have a PSA of 0.4 or below 1, let's say.
Below 1, it's not very effective. I mean, the higher the PSA, the higher the sensitivity, as PSA is a surrogate for tumor volume. So at low tumor volumes, it doesn't. But there are some new technologies that one was just recently approved that may, and time will tell, that may be even better than a sodium PET at detecting prostate cancer. So using PET scans for bone imaging and PET scanning for localized recurrences is going to continue to grow. C-choline is a big one that we use for determining where the location of the recurrence. Yeah. There's a company that's it's Blue something, I can't think of it right now, that also has incredible technology. that needs to be used and tested further.
Okay, thanks.
Yeah, I have a two-part question, briefly. First, the gentleman over there mentioned about foods.
Oh.
Are there any foods that
Yeah, getting back to foods, a great question. What foods are good for prostate cancer? What's considered a healthy prostate cancer diet? Very important. What I tell my patients is I try to get them on a Mediterranean diet, okay, which I tell them eat like a guy eats in southern Italy, okay? What that is 5 to 7 servings of fruits and vegetables a day, lots of fruits and vegetables, lots of highly spiced foods. Avoid saturated fats, use primarily olive oil. There's a lot of antioxidants in olive oil. And then avoid red meat, okay? You should only really eat red meat on special occasions. Try to eat a lot of chicken and fish. Limit your portion size of fish. Also, vitamin D has been shown to be effective, as well as vitamin D to prevent, and then phytoestrogens. I blanked for a second. Soy-based products. Soy-based products in small studies have been shown to be effective, so that's edamame, soy milk. I'll encourage my guys to try to slip in as much soy-based products in their diet. That has also shown to help improve prostate cancer outcomes. But I think what you got to keep in mind is there's no micronutrient, there's no one magic pill that's going to do it. I think when you look at the big picture, still for most guys, and I can't speak for everybody, but most guys, the greatest risk of death in this country is cardiovascular disease, okay? So we encourage our guys to eat well, fruits, vegetables, and exercise regularly. Get your heart as healthy as possible, minimize your risk for stroke, minimize your risk for a heart attack, and that will lead to the best outcomes. The cancer diet will come if you're eating the fruits and vegetables, avoiding the fried food, fast food, saturated foods. You just got to eat high quality fruits and vegetables. I think that's the key. And soy-based products is very effective.
So what's good for the heart is good for the prostate.
Pretty much. I mean, there's no secret micronutrient that you're going to take one pill of. We tried looking at selenium, vitamin E. There's a great NCI trial by Dr. Eric Klein out of Cleveland Clinic. Really didn't show as effective. I think that the most effective thing is being healthy, exercising, avoiding red meat, eating chicken, fish, fruits, vegetables, avoiding saturated fats, fast food, fried foods. That's going to lead to the best outcomes. You might slip in some vitamin D, some soy-based products, but a lot of that stuff you see on TV or you see on the internet, I'm suspicious of.
Yeah. And finally, I think you touched upon it. In terms of exercise, how does weight training and cardio?
But yeah, exercise is important because there's a lot of studies now correlating prostate cancer with obesity. So it's important that, like all things, the body's a machine. The better the machine's running, the better you're going to do. So, you got to be exercising, you got to be eating well, and that's going to lead to the best outcomes, whether you got cancer or not.
Are there other questions here? We had a few that came in online. Jumping back a bit, it says fusion biopsy uses MRI, but diagnostic MRI may not be covered by medical insurance. Could you please address that?
Yeah, MRI technology is new and it's a challenge, and it's state to state. Sometimes they're not covered. Usually they're not covered with diagnosis of elevated PSA. They're typically, you need a diagnosis of prostate cancer. It's a challenge we face. As men, we got to speak up to, politically to make sure that we're getting the appropriate test. Prostate MRI is very expensive. It's new technology, still being tested. There are definitely challenges for getting these approved, no question, and it's payer dependent.
Okay, thank you. Another question that came in, is focal the same as blue laser and or stereotactic radiation?
It can be. There are stereotactic focalized radiation where they're treating one gland. It's experimental, it's not standard of care, but it's being looked at. Blue laser is also a focal-based therapy where you're just treating a small part or half the prostate. I think the modality, whether you use radiation, laser, freezing, the concept of focal is that you're only treating one part of the gland or half the gland. You're not doing whole gland. That's the key concept with focal. The modality that you choose is going to change and evolve, but the key is that it's just treating one part of the gland.
Another question that came in online is combination hormone therapy successful or advised? For example, Xtandi plus Lupron.
Well, there's two questions. So combination therapy we typically use with radiation, okay? So we'll use, there's two questions here, and one question is we'll use combination therapy in intermediate or high-grade prostate cancer. We'll use Lupron plus radiation. That's where we'll use it. The question, what I think our online viewer was asking, was Lupron and Xtandi. Lupron and Xtandi would be used in a metastatic setting in a castrate-resistant prostate cancer. Yes, we use combination. When a guy is castrate-resistant, has metastatic disease, we will continue the Lupron and add Xtandi. So we never stop the Lupron in a castrate-resistant metastatic setting. Seems counterintuitive, but we don't have the studies to stop it at this point. It's always safer in those settings when you're dealing with such aggressive disease to use both.
Any other questions? Okay. Well, thanks so much, Dr.
Sure,
Hafron.
thank you very much.
Appreciate it. I'll trade mics. This one seems like it's better.
Thank you.
Thank you. You want it? Okay. Can we share this? You might keep answering questions or something?
Yeah.
Or? I'm sorry. Was there another? Okay. Sorry. I don't want to miss some good information if we had something that we share with everyone. Thank you. Okay. Thanks again, Dr. Hafron. And I just wanted to move forward with just a little bit of advancement of slides here. Let's see. Oh, we turned it on. There we go. Great. Thank you. Okay. So just to kind of recap and build on what Dr. Hafron was saying, we just wanted to mention that after you are diagnosed with prostate cancer, it's important not to rush into anything. You've got some time. He mentioned that unlike some cancers, prostate cancer is actually the only cancer that potentially allows you that time for choosing, and that can be a good thing, and hopefully it is, but it also puts the onus on the patient to make good choices. And again, recognizing that being diagnosed with prostate cancer means that it's unfortunately going to be part of your lifestyle moving forward for the rest of your life. Even if some guy says, you know, I've got prostate cancer, I just want to get it out of me, I want to move on. It's not that simple, because even if the prostate cancer is removed successfully, it's still going to be necessary for that man to have PSA tests periodically throughout the rest of his life. So that's still going to be an issue. So again, active surveillance when it's appropriate in terms of the extent of the prostate cancer is a very good choice to pursue, and it eliminates the potential side effects. So just be fully informed of all the options that you might have if you are diagnosed with prostate cancer, and please feel free to get a second opinion or a third opinion even. And as Dr. Hafron mentioned also, it's like he's out there to do the best job he can on your behalf as a patient, and many physicians are in that same camp where it's all about the patient, so get the information you need to make good choices. So you can't control the fact that you've been diagnosed with prostate cancer, but again, you can control how you respond to it. So it's really important to take control, take charge, get information, do your homework, visit websites, talk to other people, go to online chats, in-person support groups, whatever you're comfortable with. but it really is important to speak to others who have been there and done that. And that experience that can be shared from having gone through the prostate cancer journey is really invaluable. And that's some of what we provide in the various support groups that are all volunteer-led. So what we want to do now is to move forward with speaking with somebody who is in that situation, having been a prostate cancer survivor who has been there, done that. And Jim Nadeo is here to speak with us to talk about some of his experience with prostate cancer and the value of informed decision making. So thanks so much, Jim, for coming here and being with us and sharing your story.
Thank you, Chuck. I think, those three words that you hear, or you dread that you might hear, I have cancer, or you have cancer. I heard that the first time in October, I think, of 2012. I got a phone call from the doctor that did the biopsy, and he indicated that they had found several cores, and that my Gleason score was 7. In my case, it was 4 plus 3, which they talked about before. It's interesting when you deal with that, you go through various stages. It's almost like the stages of grief. The first thing you do is denial. It can't be me. I had no family members, anyone who had prostate cancer. I wasn't obese. I took care of myself. I ate what I thought was a pretty good diet, and none of those things there you were dealing with at that time. From there, you kind of shift in, and you go to the next stage, and mine was anger, because I had been a caregiver for decades. My late spouse was a type 1 diabetic, so I had to deal with all the situations that you have to deal with diabetes. And then here I was by myself trying to deal with prostate cancer and determine what I had to treat or to do. You eventually from that you go into, well, in my case, I think there was the level of depression. I didn't want anyone else to know that I had cancer. I didn't discuss it with anybody. I didn't want to let them know or deal with that. But that eventually shifted, and I think in that case it was after my first meeting with a doctor or one of the surgeons, and his statement was, well, if you don't do anything, you'll be a dead man in 3 to 5 years. So you reach acceptance, and you then forward on to try to treat it however that might be. Now, I was fortunate. I had a radical prostatectomy the day after Christmas in 2012. Made for a great holiday. And I have not experienced an increase in my PSA. Things are normal, and it's been 4 years. You never know whether that will come later or what you're going to experience. And you're right, your way of life is different. You have to deal with the side effects. I guess in looking at it, they asked me, well, what advice would you give someone? And I know a number of those things already have been presented here, but I think some of them are important. I think the one thing I would do is be prepared. This, unlike a lot of treatments or diseases that you might deal with, most of the doctors that I dealt with, first thing they say is, it's your decision. I'm going, well, they just had listed 6 or 7 different types of things that you can do. Different types of radiation, surgery, active surveillance. How do I decide what is the best to do? I think if you're prepared, and Us Too is great for this because they have a lot of materials that a man can look at and kind of teach themselves, or at least get up to that level. I didn't have the advantage of having that support group at that time. I was fortunate to have a group, or not a group, but I went to the University of Michigan for my biopsy, and they had reading materials, and I found a book that was done by a urologist who had prostate cancer, and he talked about all the options and the pros and cons of each one. I took notes, and I went in very enthusiastic, hoping that I would work with the first surgeon I would deal with, and he could answer all my questions. Problem I had with him was he didn't like his patients to ask questions. So we quickly had a meeting of the minds that I wouldn't go to him. And I know somebody mentioned that you can go to multiple or you can get second or third opinions. In my case, I went to 3 surgeons and 2 radiologists. You know, one thing you'll find, and this, I don't know this is a general rule, but I found it in my case, is that all of them think that their treatment is the best that you can possibly get, and they are the best ones to do that treatment. Well, how do you evaluate that when they're all telling you that this is what you should do? What I found is that with that kind of thing, you have to do a lot of, I guess, questions and try to bring out as much as you can to make that decision. The other thing I mentioned I think is important is to be cautious. Don't rush into this. Like I said, I had 4 or 5 different doctors I went to before I've made my final decision. And that was based on my age and based on what I could tolerate and based on my lifestyle, determine what I could do. But another important thing I think is to have someone there with you. No matter how alert you are, you're not going to be able to pick up everything that they tell you. They're just throwing a lot of information at you at one time. And you need to be able to bring in all that information and get that information. So I think it's important to have maybe a set of questions before you go in to meet with them and make sure that they answer all your questions. And also make sure you have someone there with you, either a friend or a significant other, that can take notes when you don't. What I found is that after I went to various doctors, that we would sit down afterwards and go through, and there was things that I didn't hear that my friend did. So I think that's very important to try to do that. It's really it comes down to it's your body and it's your life, and you're in charge in one way of the management of your care. So you can take that information, but ultimately it has to fit the way you live and what your situation is or what you're going to do. The final thing that I wanted to mention, and I didn't utilize this myself enough until after the treatment or after my surgery, is the presenters here that spoke before, men don't talk about these things, and they don't talk about them among other men either that much. An organization like us too, or any kind of support group that you can go to, you will find men that will talk about it, and they've been there. They've walked that walk. They've already been there. They know what what you're going to go through. The other thing that is really good, like I said, the materials that they provide, and also it's after the surgery, after the radiation. One thing that I found with most of the healthcare professionals I dealt with is they were very positive about their treatment and how it's going to cure you, but they understate the side effects. So they don't talk enough about, or don't tell you that, the large percentage of you are not going to be as good as you were before when it came to erectile dysfunction. Or incontinence, in some degree or another, many men have. At least going to an us2 group, you can listen to other people who have that experience and tried all the various treatments that that they were talking about before that might be helpful. Unless there are any other questions, I think that's about all I have for today. And thank you very much for letting me share.
Thanks so much, Jim. Great insight and information. And speaking of support groups, we have a list of the Michigan support groups that are printed out on the table in the back for those who are in attendance here in Detroit. And for anybody that's watching online, we have a list of our support groups on the website, www.ustoo.org. And we have them listed by state in a drop-down menu. So that's one of the services that we offer. and sort of goes into an overview of the organization. So once again, Us Too is a nonprofit that's focused on providing education at no charge. And this is kind of a quick snapshot of some of the things that we do offer. All of these are free of charge. And we talked about the 250 volunteer-led support groups around the country. Most are in the U.S., some are in other countries, but it's just an amazing group of people who are volunteering. Many of these guys are struggling with their own health issues with surviving prostate cancer, and they're taking the time, making the effort, and expending the energy to reach out and help others so they can make good choices, and they just want to share their experience. Some of the support groups are also co-led by the caregivers or spouse of the survivors, which provides another opportunity for women to go to a group and talk about those issues that might be affecting just the spouses, the wives, the partners, whoever it might be. So that's another option in some of these groups. Not everybody can make it to an in-person support group meeting, so we also have things available online. We've got the Inspire community, specific to prostate cancer. Us Too has a presence on Inspire. There's about 13 different online communities that are all categorized by topics within prostate cancer. And again, no charge. You can log on to Inspire, join that group, and then it's a series of blog posts, actually. So you can either comment on some of the blog posts that are out there, or ask a question, and you're polling information potentially worldwide. Everybody can log on to Inspire regardless of where they're at. Us Too has a 800 line, so people can call in with questions, and the phones are initially answered at the home office with a core team of people who answer the basic questions and are happy to refer on to additional information. And part of that is a second line of helpline callers. There's about 85 volunteers that are all categorized by the treatment that each person has had, the side effects that each person is managing, and they're more than happy to help and talk with these, whoever's calling in, to have a peer-to-peer conversation specific to issues that are someone's dealing with, and talk to someone else who's already gone down that path. We're in the process now of updating some of the web pages on our website specific to support group leader resource content, and providing additional information which will include a support group for support group leaders. So we'll have the opportunity for support group leaders to share best practices and learn from others, and that's just another one of the ways that we're reaching out. Every month we have a newsletter. It's called the Hot Sheet, and it's distributed both in print, and it's sent through a digital PDF online to the various emails addresses that we have in our opt-in database. And it provides a really good overview of some of the more recent articles. It's usually a little bit more scientific, but it serves as a good agenda potentially for some of these support group meetings, and it's often used for that. 2 weeks after the Hot Sheet, we have another distribution that goes out through email, and it's called News You Can Use. And we receive an RSS feed of all of the different news articles for prostate cancer. And we'll go through literally hundreds of articles and choose those that are most relevant to the folks who are reading this. And we'll put all the titles on, send it out in an email, and people can go to our webpage and download the content and read all of these articles at no charge. We have additional information that's in print, and everything we have in print it's also available on our website as a PDF. People are welcome to check that out, download it, print it out, whatever works for the situation. And we have many educational events and presentations that's happened throughout the year, and this is one of them, but there's also a lot of the support groups, they invite speakers to come in to talk about specific areas and help the attendees at the groups, and we try to do as much as we can to help support that too in terms of materials and resources. We just wrapped up the 12th annual C Blue event, C standing for Support, Educate, and Advocate. It's a group or an event in Chicago that happens every year. We had a 9/11 this year, and that was a good awareness event in addition to being a good fundraiser for Us Too. And we had about 1,200 people out there, and it was very well attended and great feedback. So we still have that website up if you're interested in checking that out. It's accessible through the us2.org website. And this is one of the events, also the local events that we have around the country that provide opportunities for us to share education and talk about the support services and resources that we have to offer the community. Another website that we wanted to mention is specific to advanced disease, and this is the menwhospeakup.com website, and it's really a nationwide movement that's increasing awareness for advancing prostate cancer. So that's another great resource. If that situation applies to you, it's definitely worth visiting that website. Thanks to all the advancements that there have been in the industry in the last couple of years, there really is real progress and real hope. And the research that's being done in the clinical trials that, again, volunteers are participating in for the sake of and the benefit of others is really making the difference. So in the last 5 years, there have been 5 new treatments for prostate cancer that have been FDA approved. So there's a lot of advancements, a lot of progress in the area. There's also a lot of challenges, too, and it's important to note that it's an average of 10 years to develop a new drug, a new therapy that's coming out it's a long process. And out of all those that start in the process with clinical trials, only 12% of the drugs are approved by the FDA. And the average cost of developing a new drug is nearly $3 billion, and that includes all the costs that are incurred with the clinical trials for the therapies that don't make it into FDA approval and aren't able to be marketed and provided to the patient community. And at this point, we wanted to kind of open it up a little bit to thanking our sponsors, some of whom are here, and we definitely appreciate all the support that the various companies have provided for us to be able to present this information and this event to all of you. So we have some representatives here. We're more than happy to, and we would actually enjoy being able to introduce whoever's interested in an introduction, being able to say a few words. So, okay.
Yeah, my name's Lauren. I'm here with AMS, now Boston Scientific, and I have information over here on this table spanning everything from urinary incontinence to erectile dysfunction. And for those of you that are following online, feel free to check out edcure.org for all your treatment options. Again, that's edcure.org. And for everyone here, come by and see me. Thank you.
Thanks, Lauren. Okay, and Santa.
Good morning, everyone. My name is Santa Wong. I'm this representative from Sanofi Genzyme Oncology. We're so pleased to be included in part of this Us to Community conversation. And I represent a product that is a chemotherapy. As Dr. Hafron mentioned in his prior discussion, chemotherapy is enjoying a big comeback, and it's a very important component when patients are considering treatment in advanced prostate cancer. And you can find out our product. The name is Jevtana, and it's JEVTANA.com. There will be a lot of education that you might be able to find out from there. Thank you very much.
Thank you. A couple of other sponsors over here.
Hi, my name is Kathy Jackson, and I'm with Janssen Biotech. We represent a drug called Zytiga for metastatic castration-resistant prostate cancer. On my table, I have a lot of information on prostate awareness, different stages, a Q&A book, and a lot of information for the caregiver. We recognize that caregivers are very important in the prostate cancer process. So thank you. I'm happy to be here.
Thanks so much. And thanks again to all of you for being here. We will be posting all of this content on our webpage as archive content. We'll have the entire presentation, plus we will go ahead and edit this into different segments and have that accessible so you can access it according to the topic. So again, thanks so much for everyone who's here. Thanks again to everyone who joined us online, and we'll be having another presentation at 1 p.m. Eastern Time today. So if there's anyone else that wasn't able to join us here online or folks here in person, please come back. We'll be doing another presentation covering the same information, and we look forward to seeing all of you then. And we want to thank you all once again for joining us. Have a good day. Whenever you're ready. Okay. Hello, and welcome to the community conversation on prostate cancer in Detroit. My name is Chuck Strand. I'm the CEO of Us2 International. We are a nonprofit that's providing educational resources and support services to the prostate cancer community at no charge. And we're very excited to be here today. And it's an important conversation that we're having. And we're very happy and thankful to be here, part of the Men's Health event, which is hosted by the Michigan Institute of Urology. And we've got a lot of good information to go through, so we apologize for the delay for those of you who have been waiting online to join the conversation. There was another presentation that was scheduled here at the Expo from noon until 1. It ran a little bit long, but it was all great information for those folks who are here in person. So once again, apologize for that delay, but we're good to go now, and hopefully you're able to stay with us. This material is going to be recorded, and it will also be archived on the Us2 website. So after the fact, you'll be able to access this in addition to whatever you want to see here live. So thanks again. We've got our sponsors that are here, and we certainly couldn't do it without all these folks, and we definitely want to thank the corporate support that we get. And it's, again, a really important conversation that we're having because it's going to cover all aspects of informed decision-making for prostate cancer. Everything from the importance of being tested to the option of active surveillance, if that, in fact, is an option for the patient, in addition to covering the various treatment options and the side effects. The importance of this conversation is, someone mentioned earlier today, as far as prostate cancer is probably the only cancer where you have the option of what you're going to do once you're diagnosed. So many times with cancer, once you get a diagnosis, there's a well-worn path between what you need to do in terms of treatment, and you have maybe a few options, but with prostate cancer, there's a lot you need to know. So in order to make good choices, you need to understand what the options are. So there's that lack of awareness. But the other reason why this conversation is so important is that there is no symptoms. There are no symptoms for prostate cancer until it's advanced. So the only way you can really detect it is with early screening. And that early screening includes the PSA test, the prostate-specific antigen. It's a blood test. And back in 2011, the United States Preventive Services Task Force recommended against the PSA because they didn't want people to be overtreated. But it's the best test we have, and we don't want people to be undertreated. So it's controversial. And it's another reason why you need to know the facts and make choices for yourself. Once the prostate cancer is diagnosed, we mentioned that there's no best treatment, and to just know that if you do pursue a treatment, every treatment has side effects. So it's important to know that up front. Word on the street for a lot of folks is that men don't die from prostate cancer, you're going to die from something else. In fact, that often is the case, but also a fact is that nearly 30,000 men across the U.S. die of prostate cancer every year. So it is not something to be taken lightly, and it's, again, information that you need to know in terms of making good choices for yourself. Because if it's detected early, it can be cured, it can be treated. The outline for this conversation is noted on the slide as far as the agenda, and it's important to note that this truly is a conversation. We've had a lot of information to go through in a couple of hours, so we wanted to have a slide deck that could serve as kind of like the roadmap for the conversation. But we do not want this just to be a presentation where somebody's talking and there's no interaction. So the folks that are here in person, please ask questions as we go through this. Those who are watching online, please comment by typing in your question, and we'll be able to get that here. And we'll print it out and ask the physicians and open it up for discussion as we move through this conversation. So we'll start with just a little bit of prostate cancer 101, go into some of the screening and testing along with diagnosis, active surveillance. We'll have some expert opinions on the treatment options and side effects. We'll hear a little bit about the education and support services that are available through Us2 and others that are nonprofits, and hear from a survivor, someone who's been there, done that in terms of managing prostate cancer. Really good information that is from a unique perspective of experience. And we'll also introduce our sponsors in addition to Q&A. And today our speakers include Dr. Elisabeth Heath. She's an oncologist with the Hermanos Cancer Institute, and Jim Nadeo is our prostate cancer survivor. So we'll look forward to hearing from both of them. we wanted to start out with just a quick snapshot of, what is a prostate? What is it? Where is it? What does it do? So this is just a little illustration that shows that the prostate gland in a man is about the size of a walnut and the shape of a walnut, and it's located just below the bladder and just in front of the rectum. And the whole purpose is just to produce a fluid that mixes with sperm. Some stats on prostate cancer. It's the most common cancer among men, following as skin cancer, and it's the second most common cause of death from cancer. And that's only second to lung cancer. As I mentioned previously, nearly 30,000 guys die of prostate cancer every year, and more than 200,000 are diagnosed with prostate cancer. And that group joins the growing majority of, or the growing population of nearly 2 million men in the United States who are currently living with a prostate cancer diagnosis. And alarmingly, as a baby boomer generation ages, that population is going to swell to about 4 million people in the next 8 years. So there's going to be a lot of people out there who are looking for information on making good choices on how to deal with the diagnosis of prostate cancer. There are some groups that are at higher risk for prostate cancer. Age is the biggest one. If the majority of people are over 65, but the vast majority are men over the age of 50. And African Americans have a much higher incidence of prostate cancer. They are 60% more likely to be diagnosed with prostate cancer compared to Caucasians, and they're unfortunately more than twice as likely to die of prostate cancer. If prostate cancer runs in your family, if your grandfather, your father, brother, uncle has had prostate cancer or has it, you're at a higher risk. It is genetic, so you want to pay attention to that. And if you are diagnosed with prostate cancer, you're going to want to make that known in your family because your sons and nephews will have a higher likelihood of being diagnosed. Military veterans who served in Vietnam or the Korean War and were exposed to Agent Orange have a higher likelihood of being diagnosed with prostate cancer. And those guys who are working in an occupation such as firemen that are exposed to chemicals and inhalants are also at a higher risk. Now, to take us through some of the information specific to diagnosis and treatment and side effects, we're really pleased to have Dr. Elisabeth Heath here. She's an oncologist with the Karmanos Cancer Institute, and she'll be walking through some information. And again, as we're going through this, please ask questions, and we'd like to keep the conversation going. So please help me in welcoming Dr. Heath. Thanks so much.
Thanks. Okay. Right. Thanks, everybody. Oh, how are you? Look, I have a fan already. Look at that. Thanks, Mr. Hardy. Can you guys hear me okay? Because I know it's loud, and I want to make sure we share information today to those of you here in person and also online. I want to welcome everybody. I'm the doctor that no one wants to see in their journey. That's me. I'm the chemo lady. I'm the one that sometimes can make you feel bad because of treatment. So we are having this conversation because it's extremely, extremely important that you talk to your doctor about your own prostate health. It's one of the scariest things about it because no one wants to think about having a problem down there. And we know that because I talk at a lot of symposiums, I host a lot of meetings, and we understand some of the challenges that people think about. And most of it is you don't want to talk about your private business. But if you don't talk about it with your doctor, you might find out about the trouble when it's too late. So we're going to talk about some of these things that you should be sort of paying attention to. So it's really a pleasure to be here. I really would like to thank the US2 organization for inviting me, and of course to Dr. Lutz and the MIU Foundation. Really, testing begins with the prostate-specific antigen. That's a blood test. So when I'm in a setting like this, I'm usually kind of amazed at how many folks don't know that the PSA is a blood test. They think a PSA is the digital rectal exam. And I've heard every term possible for the digital rectal exam. It's not that hard. It's the best 10 seconds that you will spend to try to save your life. Because if you catch prostate cancer early, it is always almost curable. If you catch it late, you're seeing me, and we are not talking about cure. We're talking about management, containment. We're talking about making you live longer, but I can't cure you. We don't have that technology yet. So the blood test is simple. If you talk to your primary care doctor, for example, we have Dr. Zhu from our family medicine group here. Go ahead and stand up. She is, thank you for being here, she's our front line. She's your family doc. Or you might have an internal medicine doc. That person is your doc. That's your go-to person. You don't feel good. You don't need to see him and her just for sinusitis or you got headaches or migraine. No, you see that person to talk about your overall health. And overall health is everything from a colonoscopy to what about my prostate, doc? How come I'm having symptoms where I pee a lot at night? Maybe it's my wife saying, you've been up 3 to 4 times in the last month or two. What's happening? And you know how many people come into my office as with that story? The majority. You get the ear pull. My wife or my significant other says, I have to see the doctor. Something's not right. So to have that conversation has to also start with you. You can have your doctor do it, but you know, sometimes the doctor gets kind of busy. So it's a blood test and a rectal examination is literally, you're right, it is using the finger up the rectum. However, we are experts. We do it all day long. And what we're looking for is lumps and bumps. So just like that picture Chuck showed us, you know the prostate's really well hidden, right? So you're not going to just see it or feel it unless it's too late. So it's really important to sort of let your doc do that. And then if that person says, uh-oh, your prostate's really big and maybe I feel a bump or a lump, what happens? Well, he or she's going to call, most likely, the urologist. So the urologist then gets involved and says, let's go see what's going on. Maybe I got to take a sample. And that's usually where it starts in terms of our journey of prostate cancer. So the blood test itself, though, is a tough one, isn't it? We've been conditioned over time to say, well, if it's 4 or below, you're okay. And if it's a little higher, maybe we'll watch it. There's no real right or wrong number. You know what matters? Trends. What are you at this age? What are you 2 years later? What are you 5 years later? What does your prostate feel like when the doctor does the examination? The other part of this is doing it consistently in a lab. So what I get a lot is people move around. Well, I got it in this health system and it was this 1 year. And then I kind of changed my health plan and I got it in this system. So then the numbers are bouncing up all over the place. Well, guess what, guys? We do the tests differently in different labs. So you are not guaranteed that a 3 in one lab is a 3 in the other lab. So I get a lot of those consults. A 3 goes to a 4, but then you go back to the same lab and it's a 3. So it's important to stay somewhat consistent. And sometimes also, it's sharing the information. I have a lot of men who do the test, but they don't know their own results. They said, well, I didn't hear from the doctor, so it must be okay. No, what you want to know is your own information. If you gave your blood, you better know what the results are. So look on your health portal. Go talk to your doctor and say, when you mean it's okay, what do you mean by that? What's okay? So empower yourself in asking the questions because it's really important. So the other part is a slightly high PSA doesn't mean you have cancer. It could just mean you have a big prostate because a PSA only can be made by prostate cancer cells or prostate cells. So if you got a huge prostate, and I mean huge, like some men walk around with the size of a tangerine or an orange for their prostate, and then they say, gee, I can't urinate. Okay, there's a problem with that. Well, sometimes it's just a big prostate, and it has nothing to do with cancer. But that number may be high. It may be 12. It may be 14. So your mind doesn't have to go, uh-oh, that's automatically prostate cancer. No, what you need is to have a conversation with your doctor and say, what is this? What does this mean? Are you afraid of cancer? What is the next step? Ask the question. The BPH, or benign prostatic hyperplasia, is what it means to have a big prostate. Now, those are the symptoms that we know. You're urinating several times at night, maybe 2, maybe 3, maybe 4, and then it becomes normal. Well, I get up that many times. You know, the cat wakes me up, the dog barks, I had a nightmare. Whatever your excuse is, if you're urinating multiple times at night, that's not normal. So you need to tell your doc, this is what's going on. I'm not sure what's happening. So that's really, really important. Sometimes also, if you've had a lot of sexual activity or a lot of physical activity, we worry that maybe that might jack up the PSA a little bit. So try to take care, if you are worried, that, do your normal activities before you get your test. So just to keep it as accurate as possible. And we also like to have the test drawn before you do the digital rectal, because once we do the examination and you're touching the prostate, it can make the cells a little bit more active, and then it can go up in number. So that's a really important fact. So we're not trying to be gross and showing you this, but it's also kind of to dispel the myths that a rectal examination is a scary thing. It's not. Is it pleasant? No. Do women like having pap smears done? No. So men, this is the time where you have to understand that for these brief 10 seconds, it can change the outcome of how your life proceeds. Because again, like I said, you get it early, it's curable. And that's what we want from this conversation. We use a glove. We have you either leaning over the exam table or laying on it, depending on the preference of the patient and the doctor or the provider. And we use a lubricant, so it's not going to hurt. And what we're looking for is the size of the prostate. And then we're looking for lumps and bumps. And sometimes a person like Dr. Zhu or the internal medicine doctor might feel a bump. Now, your prostate should be small, the size of a walnut, and it should not hurt, and we should have no lumps and bumps. Smooth is the word we're looking for. So if there is anything that seems odd, that warrants another discussion and another follow-up. Okay, so I want to make that clear that it's important to know what it is we're looking for. I run health fairs and I go out to the community and we have this little prostate model. It looks almost like a plastic thing where this is a normal prostate, this is a big prostate, this is a cancer prostate. And the amount of guys that come up and try to feel that, they're in shock at what a bump or a lump feels like. They're like, well, how can we know that it's there? Guess what, guys? You're not going to know. Only I can feel it, or your doc can feel it, because you won't feel it. It's not symptomatic. The only time you're going to feel it is if your prostate is huge, and then you can't pee. If it's really big, you can't poop too easily either, or your sexual activity is compromised. So it's really important to know what's happening with your own body. So here's what happens with the biopsy. This is the other scary thing, right? Some folks come in and they're like, okay, I think the biopsy, that uses a word that usually means a needle somewhere down here. That sounds pretty darn scary. You know what? It is scary. Don't let the doc tell you that it's not scary. When I tell my patients it's scary because you're getting a procedure, but any procedure is scary. A colonoscopy could be scary because you're put out. Here, the biopsy is something that we do routinely. Your urologist, or sometimes in some health systems, it's your radiologist that does it. So it's not just the urologist. But here, we are looking at specific areas of your prostate. So it's not like a blind stick in the sense that we're just jabbing the stuff. No, that's not it. It's a very systematic approach. And what you want now, in terms of standard, are 12 samples. Now, years ago, we used to only pick 6, and we would kind of rotate around the prostate. Nowadays, 12 is your number. And guess what? You're going to be empowered after this talk to know that for yourself. Because I see sometimes when it's a second opinion or a third opinion, I see sometimes on a report, you got 2 samples. And you think in 2016, is that at all possible? Yeah, it's possible. So you have to know yourself that, are you sure you put enough needles in here? Because I thought 12 was the magic number. 12 is the magic number. And once we get past 12, sometimes places around, even in the state of Michigan, might do up to 100 if you're really looking for something specific. But we don't do that routinely. So don't let that scare you, because I know from talking to some of my patients on some of the blog sites, they say that. I had a supersaturation biopsy. They went in 100 times. That's not the standard. There's a reason to do those, but when you're just starting out, 12 is your magic number. The other way is, how do you really know where you're going? That's where technology's gotten pretty darn fancy. So we use ultrasounds now, but there are men they're aware that sometimes when we're kind of looking for prostate cancer and you're not sure where to go, sometimes they get MRIs. So that's the newest technology. And sometimes we do an MRI that's directing the biopsy. So we do that, a fusion-directed MRI, and most centers in the state of Michigan, including at our place, are doing that routinely. So they are using different technology that's higher tech to do that. But on the whole, your standard is still your 12-part biopsy. The other part that's happening is many centers are also recognizing that maybe before your biopsy, you got to take some antibiotics. And that's because that prostate is right next to your rectum. So when you do the procedure, there's a chance of infection. So we now know that, and most centers will swab your rectal area. They know what you respond to or don't respond to for antibiotics. The doctors give that right up front, and you're done. 1 dose, sometimes 2. And that cuts down on stuff we worry about, like antibiotic resistance, right? I mean, how many more movies are we going to see about that where we don't respond? That's a reality in our world, guys. So we don't want to just give antibiotics willy-nilly, and you don't want to take them willy-nilly. So you want to make sure that you ask your doc, hey, what's the prevention of an infection in this state? So again, you're empowering yourself. The other part is the anesthesia. So some places will use local, many places will use local, not too many places will use general. So they are really dependent on the hospital system you're at, but you want to go to a place that they do this fairly routinely, because I've heard too many stories where it hurts. If you do it right, it shouldn't hurt at all. At all. And I've had men who've had multiple biopsies trying to find prostate cancer. And guess what? If you had one that really hurt, you're not going to go for a number 2, right? So it's really important that you ask these questions. And then the next question is, well, what do you see? You know, is there something like a glaring neon that says, you got prostate cancer? No, what we look for are certain words. So Gleason grades, now those of you who have prostate cancer or have had it in the audience, you're all experts in the sense most people know their PSA and they know their Gleason grade. So it's just a system that tells us how aggressive your prostate cancer is. This is stuff we grade when you look underneath the microscope. So let me walk you through the biopsy. Your materials are out, they get put into a little vial. That stuff gets sent to the pathology department. So we have a wonderful relationship with our pathologist. That person does all the prep work, and then he or she will take that sample and look underneath the microscope. And then they share that with all of us in the group and say, this is what this man has. Everybody weigh in. So we call that a multidisciplinary approach. The important part is everyone sees how difficult it is to grade it. Now, Gleason was the first pathologist who said, guys, we got to get a system. You know, if I'm calling a guy out at Sparrow or Michigan or up north, and I say, this guy has some sort of not good-looking cancer. It's really not a way to communicate with one another. So I need to say, hey, he's a Gleason 8 or a Gleason 7. So that tells us that we're talking the same language. The higher the number and closer to 10, the more aggressive and the nastier the cancer gets. So we don't often like to see 10s, but unfortunately they do show up in my office. 6s are sort of your basic low risk. So 6, 7, 8, 9, 10, those are the numbers we're looking for. And it comes from 2 groups, so it's not like it's a 6. We actually obsess whether it's a 3 plus 3 making a 6 or a 4 plus 5 making a 9. And why I care is all it is how aggressive is it? That's all I want to know. How aggressive is it? And what's it going to do? Because at all costs, we want to try to avoid seeing me. Because as a medical oncologist, I really don't want to see you guys. But I get involved if it's a high risk, sometimes if it's a Gleason 8, 9, or 10. And honestly, if you are a Gleason 8, 9, and 10, you should demand to see somebody like me. Because you want a different way to think about your cancer that's more related to what we really worry about. What do we worry about? The stuff getting out of your prostate area. So if it's swimming around elsewhere, you kind of want somebody with my skill set to be aware and say, hey, this is some new stuff we're doing here. Maybe we should think about this. not think about me after the fact, because then it's sometimes a little too late. So underneath the microscope, this is what we see. So if you guys see at the bottom where it's a grade 1, all the way up to a 5, you guys can also see, just by looking at the pictures, that the clump of cells at the bottom is really tight. It's like a ball, right? It's really nice. It doesn't show, and I'm not sure if this is does this have a laser, Chuck? No. So at the bottom, you see them all clumped together. It looks normal. It looks the same. Go look at number 5. Those are cells. Those cells lost their way. They completely have no sense about them. So when they're normal, yeah, I don't think it's working. Okay, if they're normal, they're tight, they look the same, they look just like the next cell. And when they're abnormal, look at them. They have no control. Some are flat, some are oval, some are not even standing next to each other. Those are the nasties. Those cells, they like to go out and play. They don't like the prostate anymore. They said, forget you, prostate. I've outgrown your space. I'm going to go find a different home. And unfortunately, that home, most of the time, is in the bones. That's where it likes to go. So we don't like them there, but that's what I mean about what I look for. So if I see a 5 in your biopsy, I already am thinking about the next step. So let's give a real life example of what that is. Let's say you have a 5, but you're going to get surgery because that's what the plan is, and I'm in full endorsement. But right off the bat, I already think, if my 5 looks like that picture, maybe I better be prepared to also have radiation in case the urologist, can't get it all. Or there's some stuff after it that looks so nasty that you worry that you really got to sterilize this area. And if your brain already knows that, then you're already thinking ahead to say, maybe this is more than just one treatment. Maybe I got to have 2, maybe I got to have 3 to knock it out. You get one shot to get it right, and you want to make the right decision for yourself. So that's why we empower you guys to know about what you're looking for, because that's what I'm looking for. So if you see me and you say, what does my doctor know? What's she or he really trying to worry about or come up with in the treatment plan? That's one of the major, most important. What is in my prostate tissue? So the important part on this as well is the first number out of your sum is the more primary one. So as an example, in a 9, if 5 is my first number versus 4, even though you're a 9 that starts with the 5 versus a 4 is going to be much more aggressive. So these little nuances matter for what I do, because it helps me create the best treatment plan for you guys. But you know, in medicine, we're never satisfied with the status quo. So because many of us, when we get into these discussions with our own doctor colleagues, we say, guys, you know, you're a Gleason this, Gleason that. We know that the behavior is sometimes not right. So I've seen 6s go crazy, and I've seen 10s that do absolutely nothing. So what we've decided to do is let the pathologist sort out, after their 50 years experience with this, a potentially different way to describe the cancer. So this is new stuff, where this is not even mainstream yet, but they basically want to come up with a new grading system. Guess what? Is that important for you guys? Oh yeah, it's important. Now you're going to start getting stuff back in the mail that says you've got this new grading system that has nothing to do with the Gleason. And then you're going to be more confused because there's not a lot of information. There's not a lot of information because if you look on the internet, this stuff is barely out. This stuff is barely out now. So what's important? We don't want to assign Gleason 2, 3, 4, 5 anymore, because we basically don't get that total. So to make things simple, they basically just want to have 6 and up. The thing about 6 that's changing in the past couple of years is that's the group of men who sometimes will choose active surveillance. So no surgery, no radiation, no chemotherapy, no hormones. This is just, I know I got low-grade cancer, just like I got low-grade diabetes, and I'm just going to watch it. You're not going to cut, you're not going to burn, you're not going to freeze, you're not going to do anything to me, but I am aware I have cancer, and I'm just going to follow it. So many of those folks are the 6s, but it is important to know, what does my 6 really mean? That's the discussion to have with your doctor, because not all 6s are the same. So this new grading system may be helpful for just, not us, but you guys, to have this active dialogue to really come up with a better plan of treatment. So right here, if you say, okay, let's take the worst one that we're afraid of, right? Group 5. They already put the 9s and 10s there. They did that because we actually do that already in our discussion clinically with our doctor friends. So when I sit there with a bunch of other docs, we say, you know what? The 9s and 10s, they all are in a separate category. We're very aggressive with folks who have 9s and 10s. We throw the kitchen sink, literally. If that means as much treatment up front, that's what we do, because it's important to get it right. The other part, I know there's some sunshine up there, but the Gleason group 1 is the ones that are 6s. And those ones, most people would be really comfortable doing active surveillance. You just have a little dot of cancer, just like you have a little of high blood pressure, or your blood sugar is sometimes not so great after the second Krispy Kreme donut, right? So not terrible enough to be on insulin, but enough where your doctor's going to yell at you to eat better. So we're starting to figure out not all cancers are the same, but you have to be empowered to know what the questions are. So that's really important. So speaking about active surveillance, if there is a topic that we all get into a fight at morning conference, this is it. Active surveillance is probably, not just in your world, but in our world, the scariest thing, because it's like playing chicken with your cancer, right? The question is, I have cancer. Should I not treat it right now? The general answer is yes, don't mess around. Unless you're this low grade, this group 1, this Gleason 6, as I've listed there, and sometimes even a low grade Gleason 7, still a grade 2. So grade 1s is a yes, grade 2 is on the fence, but these guys do just fine. Those are the folks that have it for 20 years, and guess what? They pass away of something else. Old age, heart disease, something else. They live to be 90-something, and you die with prostate cancer, not from it. So it's important to know, because you don't want extra treatment, right? If you don't have to get your prostate out, you don't need to get your prostate out. But you want to be confident that your prostate is being dealt with the way you want it to be dealt with. So this active surveillance is the hottest thing. You even have urologists who say, wait a minute, why are we operating? Okay, these are urologists, and there's tons of them here. I don't know where Dr. Lutz is, but the reality is their job is to operate, right? There's a problem, cut it out. They're actually the ones that are telling us, hold on a second. Maybe we don't need to do that. Maybe we got to be a little smarter about it. So the big question, as I said, is it over-treatment, or are we being foolish by not treating? So when I say we get into big debates, we get into big debates. Sometimes people stand up and they're so worked up. You're going to let that cancer go? You're going to give that guy a problem with his sexual activity because you want to get that cancer out? So it's good to know your doctors fight about your care, because no one has the right answer. But we go back to the tissue and we dissect it and we say, well, what's it look like? You know, all of the 12 biopsies all have a little bit of cancer, a grade 1 or a grade 2 or a Gleason 6 or 7. Already you're uncomfortable, right? And guess what? This man has a family history. His dad had prostate cancer. His brother had prostate cancer. His dad died when he was 70, but his brother passed away at 55. This gentleman is 52. He's got a long lifespan, but should we operate? But he's got a lot of cancer with a really not so happy family history. So many of us at that point would be uncomfortable with active surveillance. We'd say, boy, there's a lot of stuff there. There's a lot of stuff. But if you're the man that has a little dot, a 1 out of 12 with a Gleason 6 grade 1, just one core, your PSA is maybe 4. Feeling great, no urinary symptoms. He'd be the right guy to just follow. And active surveillance doesn't mean I never see you again. Active surveillance means we're just going to hang out together. We're going to work through this with prostate sample exams and digital rectals and maybe an every 6 month or year biopsy. And then we're going to say, hey, guess what? Your cancer's still pretty good. We're just going to keep watching you. Just like when you go in and you get your checkups for your cholesterol or your sugar or your blood pressure. So it's important to get empowered. Know what it is that you are asking. The other part I get a lot of questions on is, what about that PSA? I already have prostate cancer. What am I going to expect from that? So here's the easy way to think about it. If you don't have a prostate because your doctor removed it, your prostate number should be undetectable. If you have a prostate and it got radiated, you will have a number most of the time, but it should not be above 2. And I just want to put those because I can't tell you the number of times I'm at these kinds of functions or in my own practice, and people ask me that. They're like, well, I shouldn't worry, right? Because my prostate number is only 0.8. But it was lower last year at 0.2, and then after surgery, I was at 0 or undetectable. Well, I get a little nervous because when you don't have prostate tissue, you shouldn't have a prostate number climbing. So this is a growing problem, not problem, but a growing situation that we're seeing because people are living longer, which is wonderful. And they're going to the doctor most of the time, which is wonderful. But if you get a number and you don't know what to do with it, you got to talk to your doctor. So the PSA is important to work with even after your diagnosis. And depending on that, they'll tell you what to expect as time goes on. So what are some of the treatment options? You've heard some of them. There's your standard surgery. Now, surgery is already equated to robots, right? You guys have heard about robotic surgery. And if you haven't, it's the latest craze. What does that mean? It means that your urologist sits next to you while the robot arm comes and operates on you. So the days where the doctor's next to you with his arm or her arm in you is most of the time gone. So what you have is a doctor sitting next to the bedside, sometimes even in another room. You have other doctors around him, but the person controlling is the one sitting at the robot. And when you get the arm in, what they're hoping for is less blood loss, a cleaner cut, and quicker recovery time. Right now, if you go to anywhere in the state of Michigan, most urologists are offering radical prostatectomy, usually robot assisted. Now remember too, from a urologist standpoint, I have my colleagues say this, they're still operating. The robot doesn't operate with the doctor assisting. It's the doctor operating with the robot assisting. So I just want to make that clear. This is not some crazy robot that's cutting you open. This is the doctor's hands and eyes. Some of the side effects, though, is what we kind of worry about a lot. Not just incontinence, but erectile dysfunction. And why that is your sexual nerve sits right on top of the prostate. So no matter how wonderful the surgeon is, he or she will have to take that nerve away, peel it off the prostate. So somewhere in here it always gets affected. But there are ways to come, address that, and it also is on the skill level of the doctor. So you can imagine it's like anything else. If he or she operates on 2 patients a year versus the guy who operates on 200, the skill set will be different. So it's important to ask your doc. The second type of treatment is radiation. And radiation, no cutting. Radiation in some sense, and if you think about it, it's a little bit like burning, right? So you're just laying on the table, they're killing that cancer from the outside. They're putting in beams to kill the cancer and to sterilize the field. There's 2 types. External beam, which is your classic, you lay on the table, they shoot the beam. And then you have radioactive seed implants, so they call that brachytherapy. That is the doctor putting in actual seeds in your prostate, and that kills it. So it's like if you have a lawn and you don't want to cut out all the bad parts of your lawn that's diseased, you basically just put in a pesticide right where you want it dead, and then it kills it without you having to do anything else. Some of the side effects, though, are different than if you've had surgery. So we've got rectal bleeding. You might also be incontinent. You might also have problems with erectile dysfunction and so on. So they have slightly different side effects. The critical piece when you are making a decision is go see both types of doctors. So I can't impress upon you then, well, my doctor says I don't need radiation, I'm okay. Or my radiation doctor says, no, you don't need to see a urologist, I'm okay. You don't want that. You want to hear it from the horse's mouth. Go see both sets of doctors. What does he or she say? It's really important because if you go to the guy that does what he does, that's a slightly different kind of opinion than the guy that doesn't do what he does. So you need to feel good with your decision based on your values and what your experience is. The other thing you guys hear about is, oh no, I'm not going to go to the doctor. I'm not going to go to the doctor because that doctor's going to take my testosterone away. And you're right. In some instances, we have to take the testosterone away to put you in man menopause because sometimes it makes you live longer. Sometimes it's important to shut down the cancer because there's one thing that feeds that cancer, testosterone. So it is really hard, very, very hard to justify that in a lot of ways because we worry about the symptoms, and there are some symptoms. You will have no interest in sex over time. You're in menopause. You might have weight gain. You might lose your bone density. And then the thing we all hate, hot flashes and mood swings and irritation and irritability. Those things can happen, but you got to work with your doctor and your team. There are ways to address that. Don't let that be the reason you don't get treated. The one surefire way to fix prostate cancer in most instances is the hormones. You strip away the testosterone, that prostate cancer, for the most part, will slow down or die. So it is as important as in breast cancer with estrogen. Estrogen drives breast cancer. Testosterone drives prostate cancer. And then, unfortunately, in some instances, you need chemotherapy, and then you'd have to see somebody like me. But chemotherapy, even now, is still very, very well administered, well tolerated, and we have a slew of really terrific new drugs that are pills and or injectables and or immune therapy in this area. So don't just say, I don't want to see the chemo doctor, because that person has a lot of new information to share if you have spread disease. So it's important to be open to that. There are other things that's kind of around too. So the other one is what we call HIFU, or high intensity focused ultrasound. This basically is trying to kill the prostate cancer by waves. So we call that a focus beam or sound wave ablating the tissue. We don't do it as often as we used to because there's so many other techniques, but some folks, when you do the Google searches, this comes up. There are some side effects. The retro ejaculation is a weird thing that happens. So instead of ejaculating out, it actually comes in, so you don't see any ejaculate. So it doesn't mean it's not normal. It's just one of those things that can happen when you use this particular modality to kill your cancer. And then the other one is freezing therapy or cryosurgery. That literally means sticking a needle in your prostate and you freeze the actual tissue. And it kills the cells. It's amazing. But you have to be able to be aware that there's always side effects. And you can tell the side effects, same thing. It's always the stuff we worry about, incontinence and erectile dysfunction. So we just got to be careful to know when it's appropriate. But as a standard front line, we don't recommend these two. We recommend still surgery or radiation therapy. Let me do this. And then you've got immunotherapy. So everybody's seen all of these commercials on TV to have your own immune system fight the cancer. In prostate cancer, we were the first cancer to be approved for an immunotherapy. So this is an area that's still hot. We are doing active research in it. This is important also because we are using your own cells to fight the cancer. This is a little complicated in terms of treatment, but it's widely used actually everywhere, worldwide. There's also a new drug called radiopharmaceuticals. So this is using a compound called radium-223, and I'm sure you guys can remember Marie Curie way back in the day. Think back to 5th grade history class. Marie Curie actually discovered radium. Can you imagine? That discovery is what I treat my patients with today. I have patients undergoing this treatment now. This just goes to cancer in the bones. So it automatically, like a heat-seeking missile, it goes straight to the bone to kill it. It is FDA approved, and we use it routinely, and it helps a lot of patients. We worry always about these side effects, very manageable. So if you need to and this treatment is required, we think it's well worth it. The two things we worry about in terms of incontinence, it's addressable. This is stuff you have to go back to your urologist to say, listen, the Kegel exercises are doing some good, but I need a little help because I'm still leaking. I still got 2 to 3 pads I have to change at night, or it's really starting to bum out my golf game. And I kind of want to talk to you about it. Please talk to your urologist. There are so many ways that they can address this problem, that it could include, surgical procedures. They call that putting in a sling. You could have an actual implant so that you don't leak. And when done right, it works terrific. I've got men who's had it where they were using maybe 4 to 6 diapers to having no diapers and can control their urine. So there are ways to fix this, but you got to bring it up. You can't say when the doctor says, hey, it's been 3 years after surgery, is everything okay? You can't say, yeah, everything's great, doc. You got to talk about it, okay? You got to say, listen, this was okay, but I heard through one of these events that maybe you can do something a little more. And it does drive me crazy that I can't play 18 rounds of golf, that after, hole 6, I got to go to the bathroom and come back. So I think it's worth the conversation. Very, very important. The other parts that we worry about is sexual dysfunction. So I had the opportunity to run one of these symposiums in Detroit last week for my patients and others for our community. And Dr. Zhu, you were there, so thank you very much for that. And guess what our topic was? Sexual dysfunction. You could have heard a pin drop during the conversation. So many of you know it's an issue. So many of you don't want to talk about it. And so many of you don't know that there are ways we can help. So the things here, you can always use pills. My gosh, who hasn't seen a commercial, especially during sporting events, about some guy who looks happy with some gorgeous gal next to him. They're twirling around, dancing. There's always a lot of dancing. And then, whatever drug they're selling. Well, if life was that simple, it'd be great, but, we all don't live in a commercial. But it is putting a point that there are ways for you to deal with your sexual issues. That might be just behavioral. It might be a way to redefine intimacy with your partner. It may be that you want to use an actual implant. So when I said that, half the room went, ooh, and the other half of the room went, wow. So it really depends on your personality. The penile implants, they totally work. They're under your direction, under your own power. Once it's in, I have a guy who's just is so happy with it, I can't even tell you. And I have men who even think about having an implant that just horrifies him. So what's the good news? The good news, there's options. There's also a vacuum pump. Some guys, you say, a vacuum pump? Are you kidding me? No, they have vacuum pumps. And then you could put a ring afterwards, and you can maintain that erection to have, whatever level of intimacy you want with your partner or your significant other or your wife. So it's important to know there are options, because this affects your significant other. So one of the things that we've come to learn over time also is if that part of your life isn't addressed, it's pretty miserable and it catches up to you because it comes in phases. The first phase with your partner is, oh my gosh, you have disease and it's cancer. We're going to have to deal with that. So that's the first phase, and you get over that and you fix the problem and you're cured. And then the second phase is, well, we really don't have a lot of sexual interaction. Sometimes we do this, but for the most part, I don't initiate. I don't say anything because I don't want him to feel bad. I don't want her to feel bad, so let's not talk about it. And then the third phase is resentment and anger. So what you don't want is to get to the third phase, because once you get to the third phase, it's hard to go back. So know going in that the first phase is absolutely right, which is fix the problem, deal with it. The second phase is how do we redefine ourselves? And maybe it's a new relationship and maybe it's an old relationship, but every single time that couple or person sits in front of me, I'm always amazed at how different everybody is. But at the end of the day, you guys all have the same struggles, which is, how do I talk about it? I don't even want to bring it up. If I bring it up, there's expectations. So there are not just books, but there are resources. People are starting to recognize this. At our place, our sexual sort of health person does breast cancer. So she's like, what am I doing in this space? Until I tell her this affects both men and women. And we have to think together about how to help the patient be whole with his relationship. Some of the other things we worry about, like I was telling you, was cancer going to the bones. So the scary things, and you'll see this a lot when you surf the web, once the cancer is out, 90% of the time, it's like a heat-seeking missile, and it just plants itself in the bone for some reason. So because of that, we worry about not just cancer in the bones, but effect of your hormone loss on bones. So the other thing I want to empower everybody with listening to this is ask your doctor about your bones. What is your vitamin D level? Is my bone going to crack because I'm on all these hormone shots? Is there stuff you can give me so that it doesn't? If I fall on the ice, am I going to have a hip replacement? You know, do I let grandpa go out there to shovel the snow? What do we do? And, you know, in Michigan every winter, I just cringe. I have to yell at people. There's absolutely no shoveling. You got to make sure there's no, you know, ice on your steps. The amount of falls that I see is astronomical. It's every year. We're better at that now because we educate, but we also have drugs to strengthen your bones. So it's important to know that we don't have to take fractures lying down. You can be proactive about this. The other part that we worry about is pain. So you always say, like, shoot, this stuff's in my bones. You know, it's starting to hurt. Like, my back hurts, and my ribs hurt, and my pelvis hurts. We can radiate those areas and make your pain go away. But you got to tell us. So when we say, hey, is everything okay? Don't go, it's just fine. And then turn to your significant other, and you know that person's go, oh, no, he's not fine. He can't do this. He can't do that. He's popping pills all day long. You want to share your feelings and your concerns. Rib pain is extremely painful. And you know, those of you who have fallen or sneezed or broke a bone or anything, that it hurts. So what you don't want is to not talk about it. Share these thoughts because we have ways to try to tackle what's going on. There we go. Then there's the other parts, the anxiety. So I have to tell you just a quick personal story where a month ago, you know, I asked these questions, you know, how are you doing? You know, is your thinking okay? Is your life moving okay? Is the job okay? And I've gotten better at asking those questions. But where things get a little tough for me is sometimes I don't expect an answer back. So it's sort of like you meet somebody, hey, how you doing? And the answer's, it's good, I'm good. But a month ago, I was in a room and it was my usual, how you doing? And the answer was shocking. The answer was horrible, and I'm actually suicidal, which stopped me in my tracks. Suicidal, what? Yes, suicidal. So many things were going on that I, myself, as a healthcare doc, I was in so much shock that I had to take a minute, sit down and go, what do you mean? This man's been on hormones a long time. When you get on hormones, you get depressed. Sometimes you get moody. Sometimes you can't deal with things. You're overwhelmed. You got to talk to your doc. We helped him out. We did. We plugged him in. We got all the right resources. But I worry that if I didn't ask him that one particular question on that particular day, whether I would have had a chance to see him again. So we don't take things like stress and anxiety and the worry about being overwhelmed and how you can't do your job, or maybe you are in construction and there's no place for you to take a urinary break or things like that. You got to go and talk to your doc. Like, your treatment plan makes no sense to me because my job is this, this, and this. It's so important because the cancer is already robbing you of your life. You got to take some control back. So it's important with that. Okay? So that's sort of my piece of it. If you guys have questions, I'm happy to answer. Otherwise, I'm going to turn it back to you, Chuck, and go from that. Mr. Hardy.
Hi, Dr. Heath.
Hi.
It's always a pleasure to see you. Dr. Heath is the best. She's the best. I'm a 7-year prostate cancer survivor, and I had seed implant. And I had seed implant successfully. My question is, and I'm also an advocate. So in my advocacy, I'm often asked, when you answered it at the first about the examination, is the finger examination and the blood test mandatory consecutively, or can one take precedence over the other? That's just the first question.
Why don't I tackle that one before we lose track?
Okay.
We want both. That's what we want. So some guys will say, I went to the doctor, I had the blood test. That honestly is an incomplete examination. When you see your primary doctor, the rectal examination should come along with the blood test. And sometimes everybody gets busy, and frankly, y'all don't want it done anyways, and then you go, whoo, that doctor didn't want it to do it anyway, so it's all good, but you need it done. The blood test alone is insufficient, guys. Demand it from your doctor.
And is it true that all men past the age of like 60 or 70 will have prostate cancer issues? All men?
Yeah, that's a great question. So what we know now is 1 in 7 men will have prostate cancer in his lifetime. That's 1 in 7. Guess what? A few years ago it was 1 in 6, but with our new testing, it's 1 in 7. And African American men, those numbers are worse. It's like 1 in 4. So it doesn't mean it's stuff that's gonna do harm or anything, but just in the actual presence of the cancer, you need to be aware, and you need to share the message, right?
Yes. And also, isn't it mandatory that men get prostate examination? Mandatory.
Well, you and I know how we feel about that. Now, for national guidelines, again and again, they keep telling us that doing the test is not helpful because if you're going to die from it, whether you know it or not, doesn't matter. My own thoughts on this is that message is not, please don't go to the doctor anymore because you're just fine. Because that's what people hear. That's not what it's being said. However, the reality is it's not just whether you're on this planet or not. It's how do you deal with it if you do have cancer? What about the morbidity of it? So those are important things that don't get measured with a bunch of numbers and statistics. What you want is a decision or a discussion with your doctor. So you got to talk about it. So whether they recommend the test or not, that's really not the case. It's, did you talk to your doctor about whether testing was right? Even if your doctor doesn't get the blood test, let's say you guys decide not to do it, the rectal examination is still part of a yearly physical. That still should happen no matter what. But great question.
I opted for seed implant, and my seed implant was very successful. How does one make that decision, prostatectomy over seed implant, which I had, which was successful for me?
I think that's where you take into account, it was a great question. That's where you take into account, what's your Gleason grade? What does your cancer actually look like underneath the microscope? What are your other health issues? You know, are you fit enough to undergo surgery? Do you have reasons you can't get radiation? Well, does this impact your job where you can't take time off for surgery? Are you worried about incontinence more or sexual dysfunction more? Do you think that your cancer's aggressive enough or high risk enough you might need both? Do you think you're going to need additional treatment like hormones? So all of these cannot be done by yourself, this kind of thinking. You need to talk to your healthcare provider and then talk to the people around you. Talk to your peers, talk to your support group, talk to the person you value the information from. That might be a spiritual leader. That might be your primary care doctor. That might be a friend. And know that the resources are here. That might be us too. Because what you want is information to be educated.
But isn't a choice based on candidacy I was a perfect candidate for seed implant.
Yep, and the candidacy really depends on the person. So this is why options are great. There's nothing more horrible to say you only got one way to treat something because most men don't fit into one category. So you got to individualize and personalize.
Okay. My last question is a
Yes.
personal question for me. Recently, I've noticed that my nighttime urination has increased. My PSA is 0 point something, so it's non-detectable. But I've noticed lately my nighttime urination need has increased. Do you know what's going on with me?
I don't, but I know that you got to go back to see your urologist.
Okay. Thank you, Dr. Heath.
You're welcome.
Any other questions? Okay.
Oh, yes.
My name is Henry. My
Hi.
doctor, I have two urologists. One urologist wanted to give me a biopsy, which I didn't really want to take the biopsy because I was afraid of it. I was told it could cause more trouble than not taking it. I went to the second doctor, and he was talking about giving me a biopsy. But then he decided to check my blood. He did the PSA, and he said that I don't have to worry about it now. But I'm listening to you, and I'm thinking maybe I still need to worry about it.
Yeah, so you always trust your gut feeling, right? You feel unsettled with what's happened, that you had to go to another person because you weren't sure about the first person. So if you're not comfortable with how you feel about your current situation, you either got to go back to either doctor or both doctors you don't really feel, get a third opinion to be the tiebreaker. Prostate it's an unusual gland because it's so tiny, but it's hard to access. So if one worries about cancer and you don't want a biopsy, then you might be a candidate for an MRI. That's new technology. That's just new like this year. So trying to keep up with that might be something where you would get it, and if there's worrisome spots, those biopsies could be directed right to the area that doesn't look right. Okay?
The part that does worry is it says it's large.
Yeah.
And I asked him what to do about it, and he didn't say.
Yeah. So, large prostates, right? That's probably benign prostatic hyperplasia or hypertrophy, BPH. And it doesn't mean that BPH leads to cancer. So let me just say that. However, you want to feel confident that everything was done to make sure it's not cancer. And I think, Henry, where you're not 100% is you're not comfortable that that's not the case. So you want to be comfortable and be direct. Say, I'm not sure or I'm not confident in what's going on here. Re-explain it to me. Demand it.
Okay, we have a couple of questions from the online submissions. One person says, I was diagnosed with bladder cancer, and he's being treated with BCG and immunology therapy or immunotherapy.
Yep.
I've been told BCG can raise a man's PSA due to inflammation. Currently, my PSA is undetectable, and I'm concerned that a rising PSA would have the confusion of not knowing if it indicates the prostate cancer is there's prostate cancer or temporary rise due to the BCG.
So the question is a really good one. Where the prostate is located, it's literally right next to the bladder. And if you have a big prostate, why you can't pee is because things get squished. And sometimes it's so big it goes right up to the bladder neck. So it's a really tight spot. So everybody's jockeying for position. It wants its own space. The tricky part about BCG, and he's probably getting that for bladder cancer that's superficial, so it's not deep in the muscle, is that it is inflammatory. So it's a system, it kind of messes up your immune system and it makes you inflamed. But inflammation shouldn't really attack your prostate because that's a whole different level of inflammation. So for me, I would be a little bit more concerned that there's something else going on. And maybe when he's done with his BCG therapy, that they should check another PSA. And if it's still going up, he should probably check it out more, maybe with a biopsy. But that's a great question.
I've got another question that came in that said, I had cryotherapy about a year ago. My PSA in January went to 2.1, and in July it was 5.71. My urologist is concerned the prostate cancer may have come back. Was the cryotherapy the best treatment?
Well, the hard part about and we're in Ford Field, but the hard part about playing Monday morning quarterback is you can always try to second guess yourself. So one of the things I always also share with folks up front as they're talking about their decision making is you don't want treatment regret. So right now is a question a little bit on treatment regret, like should this have occurred? Now the rising numbers worry me that there's a sign. Again, we just talked about if you should have no prostate cancer, you shouldn't be rising, or if you've had it and it's frozen or burnt or whatever, it should stay the same. It should stay stable. So him rising is a little worrisome. Whether it's right or wrong, we're past that point. I wouldn't worry about that. The question is, what's to do next? And he should be more aggressive and try to find out where those numbers are coming from.
Sounds like good advice. Another question, is there any truth that Prostate and Pectasol-C can be used to kill cancer cells in the prostate?
So I think Prostate and other supplements, and I wish Mark Moyad was still here, that's up his alley. One of the challenges we have is we can kill cancer cells in the Petri dish and in mice really well with these agents. I know because one of the projects I run is using the really good parts of broccoli. So I believe in all of this approach. The hard part is when you get to the human level is that we're really efficient with our livers and our organs. So whatever's coming in usually gets processed and spat out really quickly. So to get the drug level to really be able to kill nasty cancer cells that you saw up there in terms of pictures is really hard. So I would use it only in conjunction with or in combination with regular therapy. I wouldn't use it alone because let's face it, although I know there's 1,000 conspiracy theories out there, we still haven't fixed prostate cancer. We really need to. So these supplements are helpful, and many of them are really good vitamins, and I think Mark's probably the best expert to ask for that. But to use that if you have prostate cancer right now is not really going to help you, unfortunately.
Okay, thank you. I have another question that came in online. A man in Toronto, Canada is looking for immuno-oncology, an immuno-oncology study for prostate cancer.
Yeah.
And he wants to know, is immuno-oncology the same as immunotherapy?
Yes, immuno-oncology is immunotherapy. It's sort of the branding of what we're doing now, the two fields colliding between immunotherapy and oncology. So shortening it to immuno-oncology is right. Prostate cancer studies that use immunotherapy are not abundant. There's not a whole lot of them. So there's only special centers that do them. We have several. I think in Canada, Princess Margaret will have several. So there are pockets of people doing it. It's slowly getting more mainstream, but if you compare it to lung cancer, kidney cancer, bladder cancer, the studies are not as many. So if he has access to clinicaltrials.gov, or he could try to reach me through 1-800-COMMANDUS, I can help navigate the waters, but there are many trials that are being in the works and should be live by end of this year and early next year.
Okay. And one other online viewer asked if you could please discuss in a little bit more detail the whole concept of metastatic resistant prostate cancer.
Sure. First of all, I apologize for the word castrate because that's a horrible word, and I've had many advocates like Mr. Hardy who hates those words. It's just a biological term, and that even makes it more sterile, right? Oh, that's what we do in the laboratory. Those cells are resistant to castration, which means I got rid of all the testosterone, and shoot, those numbers still keep going up. So what's happening is the ones that pop off to bone, or they like to go to liver or lungs, they have figured out a way to survive without the use of testosterone. So if I use a Motor City analogy, which a lot of my men patients get, if we have cars that run on gas and you say, listen, I don't want these cars to run anymore, I'm going to make sure we don't have any gas pumps anywhere. So there's no more gas, the cars are stalled. Until you develop an electric car. Now you can use the cars based on electricity. So prostate cancer cells do the same thing. For years and years, they're dependent on testosterone. They're growing with testosterone. They stop growing without testosterone. And then one day they say, hey, I don't need testosterone to grow. That's when they become resistant, and then they go off and do all sorts of things. Very difficult to treat, very difficult to cure. So we don't cure, but our treatment options have grown by leaps and bounds in just the last 5 years. We're making progress, but we need everyone's help. We need you guys to enroll in clinical studies. We need to hear your voice. We want to make sure we're on the right track.
Again, Dr. Heath, as an advocate, a simple question. When I discuss prostate cancer and the possibility of prostate cancer with other men, and it's an issue for men, I talk to women also.
Yes.
Because if we talk to the wife, the man usually will follow. Give me the proper name of the person I suggest they go and see.
You mean for an actual discussion?
Yes. For somebody to say, well, what do I do? Who do I go and see?
Yeah.
What is the name of that person?
That's great. Most people see a family practice doctor, or like Dr. Zhu here, or an internal medicine doctor. Because most of the time, he or she will know you the best, because you should be seeing he or she for regular care anyways, to make sure your colon is fine, your blood pressure is fine, your heart is fine. You have that primary doctor. He or she is your gatekeeper. That's the person to start with first. That person may say, boy, this is starting to look complicated. You got a lot of urinary issues. There's a lot of problems. I'm going to send you most likely to urology. So that's probably the first step after primary care.
So I send them to the
primary doctor, first step.
And then they go from there.
Correct. Yeah.
Thank you.
Great question. We're good? Okay. Thank you very much.
Thank you, Dr. Heath. That's great. Oh, do you have the clicker still? Thanks so much. That was really helpful to have that expert opinion and the dialogue and questions and both in person and online. So that's what the conversation is all about. So just to recap, we've kind of established that knowledge is power. And you don't want to rush into a decision if you're diagnosed with prostate cancer. And recognizing that it's really important to consider active surveillance if you're a candidate for active surveillance, because if you pursue a treatment, any treatment is going to have side effects. And it's always important also to get a second or even a third opinion. So even though you can't control the fact that you have cancer, you can take control of how you're managing your care and how you move forward. And the whole idea of this conversation is to get the information you need and do your homework, ask questions, access reputable websites, talk to other folks. And it's really so important to talk to the guys who have been there and done that in terms of having gone through prostate cancer and received a diagnosis and grappled with all the confusion that comes with understanding what to do as far as the best choice for moving forward, in addition to having to deal with a cancer diagnosis. That's a lot to handle. And so it's so important to talk to other people. And we're fortunate to have one of those guys here today with us who can speak to his experience and knowledge with having gone through prostate cancer. And so Jim Nadeo, we're very pleased to have Jim with us, and he'll be able to share his experience and his journey with prostate cancer. So thanks so much, Jim.
Thank you, Chuck. You know, the 3 words that you hear when you're diagnosed with cancer, I think most people who have had it can tell you, where they were when that happened. For me, that was in 2012, and I came home and I got the phone call from the doctor who'd done the biopsy, and they told me, you have cancer. And they indicated it was a Gleason 7, which was 4 and 3, and at that point meant nothing to me. But I went from there to try to learn about it and see what I had to deal with. One thing interesting with cancer, I went through stages of grief, and I initially had denial. It couldn't happen to me. I had no family members who had cancer. I was reasonably fit. I ate well. I just couldn't understand. It must be a mistake. And after that, there was anger. I was angry that this wasn't fair. Life isn't fair. I would spend a great deal of my life as a caregiver to a spouse, my late spouse, who was a type 1 diabetic. So I was used to dealing with medical issues and having someone being there for her, but there I was, by myself. This wasn't right. You eventually, in my case, I guess, I experienced depression. So I didn't want to tell anybody that I had the disease, or, even want to deal with it. Maybe it'd go away. And finally, I think you reached acceptance. In my case, acceptance was when I scheduled the first meeting with a surgeon who told me that, with my Gleason scale and what other things that they found, they figured I'd, maybe might live 3 to 5 years. So that encouraged you to do some kind of treatment. I'm lucky. I had a radical prostatectomy. It was the day after Christmas, but it worked well, at least so far. I've had no detection of my PSA is negligible, and I have side effects like many of us do, but they haven't been dramatic. But I'm lucky. I still have quality of life, and it's just a different type of life than you had before, and you do have to deal with those issues. I think my experience, I had a couple things that I would suggest for most people to deal with it. And one, I think the first would be to be prepared. And what I mean by being prepared is try to get as much knowledge as you can. This presentation that they have today, any type of materials you can read, absorb it, use it, because knowledge is power when it comes to this. In my own experience, I had my biopsy at the University of Michigan, and they had a list of articles and also books that were available. I found one by a urologist that was diagnosed with prostate cancer, and he went through all the different prostate cancer treatments, both from surgery to the various radiations, etc., and the pros and cons. So that was helpful because I could put that together, and I could give an idea of how it fit and give it helped me to think and to make a decision about what I wanted to do. Also, I think it's important to be not only be prepared, but make sure that you have assistance and other people there available for you when you're doing this. I found that prostate cancer, in my case, it wasn't something I had to act on immediately, so I could be cautious about it. And I didn't. I think I met with 3 different surgeons and 2 radiologists before I made my decision. And I know in the first example, the gentleman I met with, that it was scheduled, he was not really receptive to questions. And by this time I had lists of questions and things that I wanted to do and wanted to ask. And he told me, well, maybe when you're done, if I haven't answered everything, you can do it, then you can answer your questions. I think it gives you an idea, not only the technique that you're going to use, what you're going to do, but can you work with this specific doctor or professional? So it's important that both of those things take place. Also, it's important that you have somebody there with you. I had a friend that was with me and was able to take notes for me and to maybe ask questions that I wasn't able to answer or hadn't thought of. When you're dealing with that, you're dealing with cancer, and you have, and you're there, they're telling you all this information. It's very easy not to be able to absorb it all. In most cases, I doubt anybody does. So having that caregiver or that friend or somebody there with you that can ask that, or even afterwards go over it with you, is kind of is a very helpful thing. I know, it is a difficult decision. You have all these treatment options that you can choose from, and what is best for you, and that can be difficult. I think every professional I dealt with said that they thought their treatment option was the best for me, and they all said that they were the best one to do it. So, you have to weigh what's best for you, and it's your body and it's your life. Finally, I think the last item is utilize us too, or some organization like that. It can really help you. If you have a network, or if you don't have a network, if you have friends that have had that experience and gone through that, that's much better for you, because they've walked the walk, they've done that already. So you can ask them questions. I wasn't fortunate enough to be introduced to us too until after the surgery. So I was able to deal with some of the side effects, but not the actual surgery itself. But they have a whole storehouse of information about the various stages, and information online, as well as support groups all over the United States. So, yeah, having said that, unless there are any questions, thank you very much.
Thanks so much, Jim. It's so valuable to have that firsthand experience to share with other people, and let people know what it's actually like to go through that journey. So it's something that we'd like to include in some of our resources at Us Too, as Jim was mentioning. Us Too is a prostate cancer nonprofit that we're focused on the educational resources and support services that we are providing to the prostate cancer community at no charge. And this includes more than 250 volunteer-led support groups around the country. Most are in the U.S., some are abroad, and to Jim's point, it really does provide the opportunity for people to speak face-to-face with, peer-to-peer with other people who have gone through that journey. And it's an amazing group of people, and it never ceases to humble and inspire me to talk with these men and women who are, many of them, struggling with their own health and reaching out to help other people, and just through sharing that experience and that knowledge. So it's an amazing group of people. We have a lot of information, including the listing of all the different websites, or all the different support groups on our website, and they're all listed by state. So please visit our website at ustoo.org, us2.org. We also have an online community that is Inspire. So there are 13 different prostate cancer communities within the Us Too Inspire community. They're all listed by topic, so they're categorized that way. You can log on and answer questions, ask questions, just really contribute to a community conversation online. Us Too provides a toll-free helpline, and people can call in and ask questions. The calls are answered by the staff at the home office. And then we also have a second line or a second level of the helpline, which includes about 85 volunteers, and all these people have been categorized by the treatment that they've received and the side effects that they're managing. So it's really helpful, again, to match a caller with someone else that's been there, done that, and they can really speak from that perspective of having that specific experience. We're updating some of our web pages right now for the support group leader resources, and part of that's going to include a support group for the support group leaders, just to provide them with an opportunity to share best practices and talk to each other and make sure that we're really maximizing the effectiveness of the various groups that we have, and have a better understanding of what else we can provide to these groups and these people who are going to the groups to help them make smart choices. Us2 has a newsletter that comes out once a month. It's called The Hot Sheet, and we referenced that previously with Dr. Moyad, who's one of the contributing authors, with an article every month. And the Hot Sheet is distributed through mail and through email. And it includes some fairly scientific articles, but they're not all scientific, but a lot are really so helpful in terms of understanding what's going out there in the medical community. Many of the groups, the support groups, use the Hot Sheet as their agenda for their group meetings. 2 weeks after the Hot Sheet, we distribute online another series of free articles, and we receive the RSS feed of all the prostate cancer information that's going on throughout, on a daily basis. So once a month, we'll go through that list, compile the most relevant articles, and we'll send out an email to our database of opt-in constituents and provide that list of article titles, and they can go to our website and read all of that at no charge. There's additional educational content on the website. There's PDFs of all of our brochures, which are also available in print. We mail a lot of this out to people throughout the country and really around the world, again, at no charge. And we always love to look for opportunities like this to have educational events and share information and presentations. In addition to these community conversations on prostate cancer, we just recently had the 12th annual See Blue Prostate Cancer Walk and Run in Chicago, and C is an acronym for Support, Educate, and Advocate. And it happened to be on 9/11, so it was a great opportunity to also recognize first responders. As we mentioned earlier in the presentation, a lot of times firefighters have a higher likelihood of getting prostate cancer. And we also, of course, recognize the prostate cancer warriors in the community. It was a great fundraiser, a great event for raising awareness, and it was thanks to all the folks who participated in that. Another opportunity for education is the Men Who Speak Up website, and that's specific to the advancing prostate cancer. It's a national movement to increase awareness of the symptoms that go along with advancing prostate cancer. And a lot of the time, men that are speaking or that are dealing with advanced prostate cancer aren't speaking up about the pain they might be feeling. So it's important to recognize that, and this is another good opportunity for information online that's very helpful. So we've really talked about some of the hopeful aspects of the advancements in prostate cancer treatment, and we really have been making big results. As Dr. Heath mentioned, it's so important for people to participate in clinical trials. That's really the way that we get these advancements. And over the past 5 years, there have been 5 new treatments that the FDA has approved. But there's also a challenge, the fact that, these treatments, it takes an average of 10 years to develop a new drug, and a very small percentage of the drugs that are in trial are actually approved by the FDA. And the cost is enormous as far as the pharmaceutical industry looking to develop these drugs. They have to include the cost of all those trials that went through but were not approved, and that all has to be absorbed in the drugs that are brought to market. And just thanks again to all the folks who supported this event and helped to sponsor it. It's just a great combination of corporate support, of the men who are here and the women who are here in the audience to ask questions, participate both in person and online. So we thank everybody, and we just wanted also to go around and give those sponsors who are here an opportunity to say a few words. So some would like to speak, I know, so I'll just pass the microphone around.
Okay. Yeah, hi, my name's Lauren. Thanks for having us. I'm here with Boston Scientific, and I have information over here on erectile dysfunction and urinary incontinence. For those of you watching online, you can go to edcure.org. And again, that's edcure.org, and go through all the treatment options. But thank you guys for having us.
Thank you, Lauren.
Hi, I'm Kathy with Janssen Biotech. Have information on prostate cancer, beginning to advance. Thank you.
Okay, thank you, Kathy. And thanks again to all the sponsors and to all of you. We certainly appreciate your participation in the community conversation on prostate cancer here in Detroit. And please check out our website and let us know how we can help you. Thank you.